You, Suzanne.
Here's Bill.
Called it. Good morning, Bill. Well, welcome everyone to the final Oregon Health Policy Board meeting of 2025. Today's meeting is both in person and online participation options. So for those of you joining us online via Zoom, the Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, comments can be sent via Zoom chat to the meeting host, co-hosts. You have a supporting resource link to share with meeting participants regarding an agenda item currently being discussed. Share the link with the meeting host or co-host. Share with the meeting attendees. And all materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked in today's meeting agenda. Suzanne, thank you so much for putting things in the chat. And thank you. I want to thank Summer Bosla for stepping in last minute to help staff us our in-person side. Suzanne, if we have any online board members, would you mind pinning them? Or actually, maybe we do that from the room.
I don't know.
Michelle's going to try to get that sorted out from the Zoom.
So much. Okay, then I'll turn it over to you, Summer, to do roll call.
Oh, actually, I think Suzanne's going to do it.
Okay.
Suzanne?
Yep.
You doing roll call?
I am. Tony German.
Present.
Dr. Hemmings.
Here.
Kirsten Isaacson.
Here.
Brenda Johnson. Bill Kramer.
Here.
And Melina Moran will be coming in later towards the end of the meeting after the break. Peter Starkey.
Here. Good morning, Suzanne.
Good morning. Hayden Reclay.
Here.
And Aaron Hines, I don't believe, has joined yet. So we have 7 members present.
Great. Well, welcome everyone, board members and all meeting attendees. So we'll kick off this meeting as we do all meetings with the reading of the health equity definition. And this one, Brenda.
Thank you. It's my pleasure to read this as we ground ourselves in today's conversation. So our health equity definition on the screen here. Oregon will have established a health system that creates health equity when all people can reach their full potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. Thanks.
Thank you. And today is Brenda's last meeting. She's terming off at the end of this year. And we will have time at the end of today's meeting to share some reflections and appreciate Brenda. But I do want to just acknowledge in this moment that is appreciation for you reading today's definition and for instilling this tradition on the board. So thank you.
Thank you.
And it's one that it will be your legacy here. We will continue doing it. So topics in today's meeting, we did our roll call. We'll do a little welcome and some board updates and OHA updates. We'll then hear from 3 of the committees that are under OHPB. Health IT Oversight Committee, sometimes referred to as HITALK, Health Equity Committee, and Metrics and Scoring Committee. Public comment, We have some follow-up from our retreat, specifically the Primary Care Strategy Committee. Public Health Advisory Board has an updated charter and bylaws. And then the Healthcare Workforce Committee has a proposed new member slate for us to review and vote on. We'll share some nice words about our outgoing board member, and then we'll close the meeting. So before we begin any official board business, I want to remind all board members our obligation to disclose any actual or potential conflicts of interest. So if after reviewing today's agenda, you have a financial interest, professional affiliation, or any other relationship that could be reasonably perceived as influencing your decisions or participation in today's discussion, please take a moment to share it now for the record. And you can share actual or potential conflicts of interest. Should be shared. And your transparency helps ensure the integrity of our work, maintains public trust. And do any members have any actual or potential conflicts of interest at this time?
This is Tony German. I think just on our topic today, primary care, obviously working, setting up primary care. I have no financial interest directly related to this topic, but obviously a clear support for this initiative.
And I would echo Tony's sentiment, neither a financial interest and a deep degree of passion for this topic. So excited to talk about it today.
Thank you so much. And with that, we will consider the OHPB draft meeting minutes from our last meeting. So our first order of business are the November meeting minutes. Draft meeting minutes are included in today's meeting packet as attachment number 1. Is there a motion to approve the draft OHPB meeting minutes?
So moved.
Peter?
Second, it's Tony German.
Thank you for seconding, Tony. All those in favor of approving the November board meeting minutes? Please say aye.
Aye.
Great. The meeting minutes are approved unanimously. Great. So we have recently gained, we'll move on into OHPB business and updates. We've recently gained 2 board members. Really welcome Hayden and Aaron. Aaron has been confirmed by the Senate, will officially join us as a voting board member in January. And sadly, we say goodbye to 1 board member today, Brenda. But even with those, we still have 1 open seat for a non-healthcare member to join the Health Policy Board. So to everyone attending today's meeting, if you're interested in becoming an OHPB member or know someone who would be interested in applying, please review the OHPB new membership application and apply through Workday. We'll put Suzanne or Michelle, someone will put the link in the chat, and it will be in our meeting minutes and is on our website. So our plan is to solicit applications for OHPB membership over the next several weeks and convene another OHPB member-led governance council to review the applications and share new member recommendations with the governor for her final recommendation to the Senate. So we will be looking for a couple board member volunteers to serve on the governance committee. We anticipate that this committee will probably meet about 3 or 4 times, an hour each. Conduct some kind of conversations, interviews among the top candidates. So approximately time commitment of 5 to 7 hours in the January, February timeframe. So if you're interested in participating in that governance committee, let me know now, let Tara know, Tony, myself, whatever feels comfortable to you.
Yeah. Question, who's that position replacing, or is it a role that we have had open vacant for a while?
It's currently vacant.
How long has it been vacant?
A while.
2 years?
We have, I don't know if it's been 2 years. We have submitted recommendations, but the governor has not recommended anyone to fill that seat yet. So we will be exploring what they're looking to see in that seat. In addition, we do, like is done on all the committees, we do the same gaps analysis to say where are, are there geographic regions in the state that aren't represented on the board? Are there areas of expertise that aren't represented on the board? And keeping that in mind as applications are reviewed. And we will touch base with the governor's office to be like, what are you looking to fill as well?
Thank you.
Okay. Let Tony, myself, or Tara know if you're interested. All right. Our second order of board of business is to acknowledge a transition in OHA staff. And after 15 years of service, I just want to recognize Ellen Finney here, who attended us, advocating for Medicaid members so strongly. OHA, the Oregon Health Authority's first ombuds.
It's been a total pleasure and a privilege. Ran into you out in the hall. The person who is taking my position will become the new principal ombuds. I think is on the phone, Brooke Emery, coming up with Sarah to this meeting. I hope you guys have a chance to meet her. It's been totally my pleasure and privilege to serve people in Oregon as an advocate for folks with Medicaid. And I don't intend to leave that role once I leave state service. I will be taking a little break, but like many of you, my advocacy will continue for healthcare overall.
Thank you.
Thank you, guys.
And I just like to take the ombuds program from one person to eight,
Yeah, now 10.
10, to really like systematize and create an infrastructure around Medicaid advocacy and voices within an agency is no small feat.
Honestly, I had much less to do with that than Sarah Dobra, who's on the phone, but my job was really to teach how to advocate for folks with Medicaid. So and to mentor others like my colleague Kate here, senior ombuds with our program. Sarah Dobra has been amazing to work with and the fact that agency leadership said, yeah, no, you can't do this work anymore. It's just one person. After I think there was a big call out on the family care. Remember the family care thing? Right? Oh, you have a problem, you call Ellen Kinney. My boss at the time said, yeah, I think you've got a team.
Wow.
So it's been a privilege and it's been exciting. We appreciate Health Policy Board's interest in the work that we do and the recommendations we make. So thank you for your own advocacy.
Thank you, Ellen. We wish you success in your next adventures, and also, vow to continue to holding central the ombuds observations and program. It plays a really essential role, agency and state. And with that, Ellen mentioned Brooke Emery, who will be our new principal ombuds person. Had the pleasure of serving on this interview committee, actually, and so I'm excited to welcome Brooke, and we'll be hearing from her, and the MAC actually will probably be working closely with her as well. So to our liaisons to the MAC, Ellen will become a familiar face. Great. With that, I'll turn it over to you, Claire.
Great. Well, good morning. Excuse me. Morning, everyone, and good to be with you all in person today on this rainy day. I wanted to just provide a few different updates around federal response in particular. So the first kind of big effort that we are working on in response to HR1 is determining what our budget needs are to actually implement all of the changes that are necessary under that law. So we've been working closely with the governor's office, with ODHS and the Legislative Fiscal Office to define those asks. And there's really kind of two pieces of that. The first is better assessing what the impact will be of lost federal funding. So there are a number of changes in the law that dramatically change how the state can fund and finance the Medicaid program. And so we need to request general funds to continue that work at the current levels. And so that's one piece of it. And then the second piece will be actually the work that needs to be done to implement some of the new changes, including the eligibility changes and work requirements, or as CMS refers to them, community engagement requirements. And so we are really focused on prioritizing where we can, leveraging technology to automate the process as much as possible so that we are minimizing the number of people that actually have to go through any kind of paper process or electronic process, but that we're using the data that we can and technology in a way that really tries to center as much as possible the consumer experience here. And that's been kind of core of how we're thinking about the funding asks as well, which will be for some technology support, but also for additional eligibility workers, because this will also include much more frequent eligibility checks on the Medicaid side. So that is a partnership request with ODHS, which runs the Oregon eligibility program. Regarding Medicaid, we are still waiting for more specific guidance from CMS about some of these requirements. CMS did release yesterday guidance around some of the components of the law, and specifically some of the work requirements / community engagement exceptions. It's not at a level of detail that is necessary to implement these changes, and we are expecting actual rulemaking on work requirements in particular by the end of June, which I think I've mentioned to this group before, just really puts us in an incredibly tight situation because we need to implement those changes by the end of next year. So if we're not going to get the real rules of the road here and yet need to implement really dramatic system changes, that constrains our ability to do so. And that makes it kind of uncertain as we're trying to estimate what the costs will be, because we know that the rules might be changing. So just a couple of things to keep in mind there. We, in our work, are also waiting for more word from CMS about the Rural Transformation Program funding. So I believe I mentioned last time that we submitted the application for that funding, and we submitted an application that was in line with the Notice of Funding Opportunity, which requested a budget of $200 million per year for 5 years for that limited time funding. But we know that the kind of base load, we should be receiving $100 million per year. And then anything above that is discretionary. There are some specifics in the way that CMS has defined technically how funding should be distributed based on rural demographic factors of the states. But a good portion of that is left to CMS discretion in review of the application. And so we would expect to start engaging in budget negotiations this month, because CMS has a deadline of December 31st to make award decisions. So by the end of this month, we should know more about what we're working with in terms of that amount. And I think, as I've spoken about in different forums, the limited time funding we know is not going to anywhere near replace the lost Medicaid funding from this law, but we are looking to, as much as possible, ensure that we are pushing awards out to communities and providers and rural practices that can use this funding for allowable uses under this program. And so as we await the information from CMS, we're taking some proactive steps to better define what those projects might be, who and what entities might be requesting that funding, so that we can start to get some of the specifics in up and running. And so we did release a statewide intent to apply survey that's open until this Thursday. And we can also put that in the chat. And the intent there is to gather input from community partners and organizations that would be interested in applying once funding is available, so that we can start to get a sense of the potential work projects that the applicants would be proposing. And it's a non-binding survey, but again, helps considering that we will have a very short window of time to actually make funding awards in the first year of the program, because we're operating under a federal fiscal year. So the funding will end by September of next year. And so we just have a really short window of time to actually get a program up and running. We need to ensure that it is built with integrity, and that we are monitoring and being good stewards of the funding. And we have additional reporting requirements. It's a cooperative agreement with CMS, which means it's a lot more involved in terms of a grant program. And we would expect that to continue throughout the period of award. And so we need to stand up a program to be responsive to that and not jeopardize the ability to receive funds in subsequent years for all 5 years of the program. So those are some of the things that we're working on right now. And I would say it's been incredibly helpful to get input from the public so far. We did a survey before the notice of funding was even announced. We did one while we were writing the application in 6 weeks. And so that engagement has been really helpful to make sure that we're moving in the right direction, and making sure that the funds can be directed to where they'll have the greatest impact. We continued to have listening sessions and intend to provide information as much as possible to ensure that organizations are prepared once this becomes a real funding opportunity for the state. So more information we would expect more specific information about, for instance, requests for application would be coming out around the end of the first quarter of next year, because again, we need to get our program up and running to be able to distribute that funding. So I'll continue to provide updates as we have those available. And I think the only other thing I wanted to note, and then happy to have a discussion, the board had requested that we regularly provide an update on the Personal Responsibility and Work Opportunity Reconciliation Act. And on that updated interpretation, there's no changes to report at this time. OHA is still operating under the court injunction, meaning we are still in a non-enforcement period. So again, wanted to make sure I provided an update, even if it was no update at all. So with that, I'll turn it back over to the chair.
Thank you, Claire. Are there any questions for Claire? Yeah, go ahead, Dr. Hemmings.
Yeah, I made a note here as you were speaking. You mentioned cost when you referred to the work requirements. Question, how is cost being defined? And because I asked that question because I'm thinking that there's the cost of implementing, and then there's the cost of those who end up not being eligible for benefits.
So when I was speaking of cost, I was specifically speaking about the general fund that we will need to request to pay for the state's administration of the changes. And so I think what you were getting to is a very good point, that we also are interested in monitoring and are thinking about standing up programs to evaluate the actual impact on people that will be impacted by these changes. So that's not a part of our budget request, but is something that we are requesting budget to be able to monitor and report on over time.
Okay. So is there a plan to actually incorporate that as you are looking at the general budget funds cost related to the implementation for the state, to monitor, work requirements? Because I think they should happen together.
Yes, we are including in the budget request what we would need to perform that monitoring and additional analysis, and also requesting funding for additional community engagement. So we recognize that there are a lot of changes that people are going to be navigating, and ideally they would understand upfront how to navigate those so that they are not falling through the cracks of, or, you know, being kind of prevented by administrative red tape from continuing to maintain their eligibility. And so we are kind of balancing the automation I talked about on the technology side with ensuring we have really strong customer service so that those kinds of frequently asked questions can be regularly monitored and responded to. And so that piece of it, both the kind of human touch side as well as the data analytics side, we are hopeful that that will give both the quantitative and qualitative aspects of what we're hearing on the ground and can monitor over time.
Do we have any idea right now as to what the data looks like in terms of what percentage of the population who currently receive those benefits will be impacted? And maybe some ideas as to what percentage of that population may not be able to, for whatever reason, meet the requirements. Do you have any preliminary data on that?
Yes, I do not have it at the tip of my fingertips, but I will be sure to send the initial financial impact that we did as an agency and shared with the public. And part of that is looking at what is the total populations that are currently enrolled and that are impacted by particular policies in HR1, because there are some exceptions for each of these, or in some cases, they're only applying to the Medicaid expansion population. And so we know how many people are in the adult expansion population, but we don't, for instance, have data at the moment about how many are working. That's not information that we collect. And so we can only provide estimates. We've done some of that estimation based on the experience with public health unwinding and how many people were, potentially eligible but not completing paperwork, that sort of thing. And so we've done some of that, and I'll be happy to share that financial impact, but we don't have at this point really discrete numbers on how many people may be eligible or not according to the exceptions. And the information from CMS is not providing us with that level of specificity quite yet. I think one of the big questions when it comes to exceptions is around medical frailty, which is a definition in the law, and the guidance that CMS released yesterday did not provide additional detail on how that would be defined. So there's, we're kind of getting like the breadcrumbs of trying to build towards this, but that's one of the biggest question marks at this point.
And it's it's going to be very important to include service providers and community organizations in terms of how do they assist, their members, their clients, the ombudsman's office, in terms of navigating this, because there's already a lot of anxiety around that within the community. So I think including that as well would be very important too.
I agree.
Good. Brendan and Hayden, thanks so much for the report. I wonder if you can educate us a little bit about where the conversations sit with the provider tax right now. What's allowed and not allowed is one of the mechanisms the state has to pull and leverage funding. So I don't know where those conversations sit. It's such a big existential body.
It is, and I think that this biennium, there's less impact. So there's some of the changes start to go into effect this biennium, but it is in later bienniums that we will really feel that full impact. And so I think it's at a stage of needing to plan for that as we're looking at future budgets. The way that essentially the caps are going to ratchet down over time, there will be a long tail to that impact. So we will have time to plan, but cumulatively, the impact of that lost federal financing is going to be incredibly significant. And so, for better or worse, we do have a little bit of time to plan for what that will actually mean and what the state will have to take on in terms of general fund to replace that lost federal funding.
And is there a multi-state coalition building around adjusting the policy, reversing the decision in essence around how
this particular mechanism is used to finance Medicaid?
Not that I'm aware of. We do participate in a number of different national organizations, including the National Association of Medicaid Directors. And so although those associations don't necessarily facilitate joint state advocacy on particular policy areas because they are representative of the entire country. And so I'm not familiar with any of those groups that are doing something similar, but happy to bring updates if I become aware of those.
Just thinking about multiple states who are in the exact same position that Oregon is in and use a similar mechanism, and whether or not there's synergies to be built,
Yeah, I mean, I think most states are managed care, and so everyone has been relying on this as a financing mechanism for years, and undoing that is something we're all grappling with at the same time. But in lieu of Congress changing their federal legislation, we're just in a period of needing to adjust to it. Thank you.
Hayden.
Hayden Rickley, thanks for that, Claire. A couple questions on the revenue generation side. Are you guys thinking about revenue for financing for dealing with the Medicaid, or dealing with the work requirements and other administrative things, or also lost revenue from provider taxes?
At OHA, we're in a position of requesting the funding that we would need to continue to administer the program at the levels that have been approved by the Oregon legislature. And so that's what we've put forward or putting forward in terms of a budget request package. I think on the revenue side, one thing just to keep in mind is there is a little bit of a balancing factor here, given that there is going to be reduced Medicaid enrollment. And so that will produce some savings, as it were, to the current budget that we need to administer the program, because we will have less people on Medicaid. So that's when you kind of see the numbers, right? They're net of that. I think the revenue conversation, though, is one that we have to continue, and there's no specific solution at this point.
Yeah. Okay. Yeah, that was going to be my second question about this, balancing, because obviously, based on whatever you're predicting from losses, state share to fund those, beneficiaries is going to accrue to some sort of savings.
Right.
This gets back to, I think, the question before about what's the modifiable number here of beneficiaries versus those who are kind of per se going to be ineligible.
And that's what frankly makes this so hard to predict, because not knowing exactly how CMS is going to regulate that makes it really difficult for us to do any of those kind of caseload forecasting with a level of accuracy that I think all of us would prefer.
And does the state expect, in terms of savings, again, we would also be talking about state direct payments, and I guess that's a function of, I forget when exactly those kick in, but at some point that also would be expected savings to the state.
I don't know if we would count that as savings, and I will apologize because I might start to get over my skis a bit on the budget pieces and need to come back, but that's kind of lost funding for us in terms of funds that we are utilizing to finance the Medicaid program. So that would still be, I think, counted as a loss when we're looking at the overall lost revenue to operate the program.
Yeah, I guess I'm just thinking net of the state's contribution to that.
Yeah.
Amount, but this feds probably kick in more than
in terms of the match. Yeah.
Always nets a little bit of a loss. So many moving pieces. Thank you.
Last question will come from Tony.
Yeah, thanks, Clever. This is Tony German. Back to eligibility, and it sounds like this still remains a moving target. We're not going to have clarity on that for theoretically 6 months as far as that rulemaking. Back to just leveraging technology, I'm very interested in this, and also the partnership of the health system itself, right? Because we're the first point of contact, and I know that just in my own institution, we do a great deal of trying to vet that and support that. And it's in our interests to make sure our patients can still have coverage. I just wonder about the technological platform. Historically, some of this has been on paper, and some of our community members, that's where they're going to need to, because they don't have the access to the technology and stuff like that. But I would make the observation that, in the patient population I serve, which is very marginalized, does not have they all have phones, right? A good majority of people. And so leveraging that as a tool that automating and say, hey, you qualify for TANF, you qualify for those things. So I imagine some of those will be in place to kind of automate that process. But could you speak just how we're engaging our health systems and how we can partner with the IT systems in those institutions in our clinics and things like that we can facilitate that?
Absolutely. And I would say the one thing I would emphasize around the automation is it's automation to ensure that we can look at data or other sources of information to determine whether individuals are eligible for exemptions without them having to interact with the system.
Yeah.
Right. So when we're thinking about automation, it's let's cut out any time that anyone actually has to interact with us directly. But there are those experiences where people do need to interact, or it's a complex case, or people have questions. And I think that is where both call center, what we learned from public health unwinding is there needs to be kind of a multifaceted approach at providing information. We need to be able to fund community-based organizations and trusted messengers to be able to have those conversations where people are at. We need to ensure that there is some kind of call center resources that are just the basic frequent, what site do I need to go to? What form do I need to upload? Those kinds of questions. And then we need state staff to handle the eligibility piece of this. And so it will be kind of multifaceted and in a way that makes sure that people aren't falling through the cracks. But I think that first piece is what you're talking about, is ensuring that we have those connection points with community, with providers that are interacting with patients. And that is work that we still need to do. And in part, it will be obviously informed by the trainings and types of things that we'll have to develop once we actually know the rules of the road.
That's great. Yeah, I just think nowadays we have so many apps, and so people are accustomed to that. That having something that just says, hey, I'm on here, I'm on Medicaid currently, just tools that might leverage that. We have so much with AI with that. I have one other little thing.
Okay.
I don't know.
We're going to squeeze one more in after you. So.
Okay. And this is for a future meeting as far as the bridge program. And I'm just curious what will come after this month. We'll have to see. But I think there will be some really critical impacts to that program. I just would like to see more of that discussion with what happens with the ARPA subsidies and whatnot. So I think it's something we should pay attention to as a board.
This is Peter Starkey. Claire, I really appreciate that the state is looking at kind of those investments that the state makes. I'm also wondering about whether there is intent or collaboration for the next layer beyond that. And I'm specifically talking about community partners that have been supported by the CCO system or by those that have received a lot of this funding, hospital CCOs, even other insurance companies as well, that because of these budget cuts are now having to right size a lot of those things. I'm also thinking about the quality incentive program. There's a lot of kind of outside of the immediate CCO and hospital system, there's also a massive social safety net that's rapidly disappearing. And I think about here in the Portland region, the announcement that all of the counties collectively are losing $15 million from their contract with HealthShare. I think it's HealthShare. That goes to critical intensive care coordination, the choice program, a lot of things that are really high priority for OHA in the state, and losing dozens of that workforce. So just kind of asking if we're making sure that not only are we focusing kind of on the immediate inner circle, I know that you guys are so strapped, but just kind of the further impact, because I just worry that if that's not being taken into account, then we're budgeting, we're trying to fix a hole that maybe isn't getting the full picture of what could potentially happen in that secondary or tertiary space.
Yeah, I think it's a really important point, and certainly something that we're not losing sight of, and trying to make sure that we're continuing to engage with those community-based organizations with FQHCs and kind of hearing as everyone is kind of adjusting to this new business model, that we are partnering as much as we can to make changes where possible to make things easier. The ability to replace that funding is something that is not necessarily on the table. And so really our budget requests right now are focused on here's minimally what the state needs to comply with the federal law so that we don't lose all of our Medicaid funding.
Yeah.
And so I think the next stage will have to be kind of the points about like what are the true costs and impacts of this to the broader system. And I think the ability to have a monitoring system in place will also help with that, to make sure we're not losing sight of or losing documentation of what we've lost as this funding has gone away.
Thank you.
Thank you. Cool.
I'm making just a process suggestion
Yes.
and request. Seems like there's a ton of issues here, and we need more time to listen to this and ask questions. We didn't even touch on vaccines. We didn't even touch on, we only got a little bit on rural health transformation. There's a lot more coming on that. Didn't touch at all on the loss of premium, enhanced premium tax credits in the ACH marketplace. So our suggestion is that we devote a larger percentage of our time to these kind of updates that gives us a chance both to ask questions, but also to weigh in where there are some decisions to be made to offer guidance to OHA.
I think I'd like to build on that and suggest that the board offer questions in advance so that Claire can prepare. You know, because I think if we can organize our thinking or you all can organize around like which are the hot topics that we definitely want to speak to in that upcoming session, that would also become, I think, really useful for the team to then know what to respond to.
Yeah, I think questions in advance, so because we can request it for sure. And then I think coming out of a retreat, we recognized that we had this kind of broad federal response bucket. I think if there are specific areas related, I think we at the time labeled it as like HR1, but key areas of federal changes that are coming down that we would like to have a longer presentation on and provide input on. There's space to identify those. And so let's try to do that over the next meeting, and then we'll provide that to OHA. So it's both within these update times, but also could have specific agenda topics. Great, thank you. And thank you, Claire, for the conversation and collaboration and work overall.
Happy to continue it in whatever format's helpful.
So with that, we will turn to our next agenda item number 3. Leadership from 3 of the board's committees are joining us today to share about their work progress and plans. A board receives quarterly updates from committees in the quarterly committee digest, which provides a really comprehensive view about activities happening within committees. But also we want to value this in-person time with our committees, cycling through a few at a time over the year to really share and discuss their work. So appreciate the leadership from Health Information Technology Oversight Council, the Health Equity Committee, and the Metrics and Scoring Committee being here today, representing their members. So the format of today's updates includes like a 5 to 7 minute update from committee leadership, followed by 5 to 7 minutes of time for questions and discussion among the board. So we'll do that in a set of 3. Before we move on to the next committee. So first up, I would like to welcome David Dorr, Chair of the Health IT Oversight Committee. Hi, Tuck.
Thanks,
Dave?
I appreciate. Thanks a lot. Appreciate you having us, and I will try to be brief given time. Can you see our slides? Are they up for you all?
They are coming up.
Okay.
They are here.
Okay, you can go back. So my name is David Dorr. I use he, him pronouns. I am a professor and chief research information officer for Oregon's Health and Science University, and I'm the current chair of the Health Information Technology Oversight Council, or HITOC, but I'm very glad in this presentation to introduce our next round of leadership, as well as our recent work and our plans for 2026. So if you go to the next slide, I'll just let the other leadership introduce themselves.
Hello, everyone. Amy Henninger, she, her. I am Multnomah County's Community Health Center Medical Director, and I am the current vice chair, outgoing vice chair of High Talk. I've been on High Talk for 10 years.
Good morning, everyone. My name is Christina Martin, she, hers pronouns, and I am the Chief Information Officer at Curry Health Network. I am currently the chair-elect or incoming chair, and I've been serving High Talk since 2022.
Hi, Jennifer Chi, she, her pronouns. I'm the Director of Digital Experience at Care Oregon. Prior to that at Kaiser for about 10 years. And I'm the incoming vice chair. I've been with High Talk for about 2 years.
Great. Thanks, everyone. If you go to the next slide. What is the purpose of the High Talk? Essentially, it's founded on the premise that health IT is foundational to healthcare and a key element in transformation. And our purpose is to support the board priorities, including healthcare affordability, administrative simplification for primary care, and innovations in rural healthcare delivery. I'm so pleased that Christina, who is at Curry Health, which is a rural healthcare network in the southwest of Oregon, is going to be our chair-elect. That seems very important as we're moving forward. There's a focus, obviously, on health IT at the federal level with a number of CMS and HHF's initiative calling for technological innovations, including in AI, and also to support rural health and enable direct patient engagement. We're responsible for setting in High Talk, setting and overseeing the state's health IT strategy. And our principles are to support healthcare quality, equity, and patient access to information. Our responsibilities are high priority policy topics, which I'll go over our next set in a second for 2026, assessing our health IT landscape and reporting on progress, monitoring the federal health IT law and policy, and overseeing OHA's health IT efforts. We support coordination around information exchange, including HIT Commons, public-private partnership, the Emergency Department Information Exchange, ED Point-Click Care Platform, and the Prescription Drug Monitoring Program Initiative. So we also support coordination around community information exchange, which brings into health information exchange community-based organizations and other human service and agencies. If you go into the next slide. So our focus areas this year, as you might imagine, artificial intelligence or AI use in health IT is sort of bubbled up. I'm the chair of AI governance at Oregon Health and Science University. So we've really been looking at this in terms of state and federal guidance, emerging ideas around that, and then also a number of the health equity implications of using AI. We just summarized an updated report from HHS on this topic. But our biggest focus for the year so far has been behavioral health. This is a key focus in our strategic plan. And as you know, behavioral health organizations really lag behind other health-related organizations in adoption and use of health IT. They were left out of high tech. And that really limits important electronic data sharing between these incredibly important providers, both within behavioral health and with everyone else. So we looked at the current landscape and really what's being done to address this. And then we heard directly from a number of CCOs and behavioral health providers, which was incredibly enlightening about what has worked and what hasn't and what still remains. And then a number of the equity considerations in this area, and then explored options for how we can support, how High Talk can support greater adoption of health IT and behavioral health. And then finally, we have a set of recommendations to advance health IT for behavioral health providers, and we'll continue to focus on this and refine these. In August, we discussed patients and consumers' use of health IT because this is growing very rapidly, and the use of mobile health apps is on the rise. There's a number of state and federal initiatives to support patients and consumers. There's a number of patients' concerns we discuss around privacy versus the potential benefit, and have other considerations going on there. And then finally, we talked about health IT for social determinants of health needs and how to use those. How do we design health IT to implementation and use of health IT to center health equity, especially to support social determinants of health, which are very complicated, especially in community information exchange and other ways of exchanging this information appropriately. So we really are looking at the way CCOs have been working on this and the barriers and trying to find promising practices. If you go to the next slide. So what are we doing in 2026? Well, we're going to talk about rural health transformation, obviously, and other OHA prioritization work. We're trying to adapt as things change. So I'm really thinking about what are the issues for rural providers, what are the potential for AI use? How can that be helpful? How can we engage patients and consumers more in rural areas in the use of health IT? And then also really thinking about health IT and behavioral health in rural areas. So beyond that, we really have heard from behavioral health organizations who don't have a functional electronic health record system, really. What functions and needs they have to improve their connections across and between settings, and trying to really track the EHRs that are in use and their functions, because that is not clear for behavioral health providers. We also may also explore governance of health IT in Oregon, and then, of course, we're going to keep focused on the health IT implications of the changes at the federal and state level. And I think we've got a good cadence for this, really trying to get rapid updates and feedback in. I will just say the staff of our committee are incredible. It's a complicated technical area, and Laurel especially does an incredible job. So I want to say how thankful I am to them. Go to the next slide. Here's the contact information. Marta has come on relatively recently. Her expertise is incredible in behavioral health and in health IT as well. So I feel like we're well served overall. However, we would really love a committee liaison from you all. So please join us. It's a lot of fun. Thanks. I'll stop there.
Thank you, David. Thank you, High Talk team. I will echo. I was a High Talk liaison for a long time. It is a great committee. Yes, noted. I'm not looking at you, Peter. I know you got plenty of committee, but you're welcome to it if you want it. Any questions from the board for High Talk? Go ahead, Bill.
Thanks very much for this update. An impressive range of work. We hear a lot of concerns from providers and others about billing and administrative complexity. To what extent does that fit in? I know it's not only an IT issue, but to what extent is that part of the work that you all have been doing?
I mean, we're concerned about the degree to which health information technology adds to administrative complexity. As you know, EHRs were set up to manage documentation and billing, to recoup the costs of healthcare entities installing them. And I think we've discussed a number of ways that administrative simplification can occur in EHRs, and really have been pushing for really soliciting ideas and thinking about how we can improve the usability and usefulness of EHRs, thinking about, as new initiatives come out, how health IT can help make them simpler rather than more complex. If you've been using AI in your practice, then there are ways that is helping, but there are still a number of concerns in that way. I do think we're in a new era of health information technology, and so hopefully we'll see that happen. But you're right that a lot of the administrative complexity is beyond, it's installed in a way in the health IT and it can make it worse, but a lot of it just comes from outside policies. So I don't know if others on the committee have a response to that.
I would just add that this is something that has come up in particular for behavioral health organizations, and it is it's a functionality that is often needed for behavioral health and may potentially be something that draws them into health IT because it is such a need for them. And so that's something that we are also further exploring in our behavioral health work, is to what extent are behavioral health EHRs designed to support that need. And they have very complex billing needs because of all the grant funding that they have. And so it is a different, it's at a different level than for physical health. It's just different. So it is something that we have heard a lot over the years, and something that we are looking at for supporting behavioral health with EHR adoption and other health IT engagement going forward.
Questions coming from Tony?
Yeah, Tony Durban, thank you all for your work and really valuable and important attention as we're seeing so much development from technology and utilization of health information exchanges, as well as the complexity of our electronic health records. Over the last, decade, we've really invested in value-based care, and Bill covered this a little bit of the complexity and administrative burden. Some of it is the exchange of information that has to take place for billing and for our quality incentive pool dollars. And I'm just curious about the attention of HITALK in that realm. And along with this, I'm curious about our learnings and what your investigation, and perhaps other states, to facilitate the ease and making it more simple, really. And I call that just one system. I'd be curious about your body of work as far as in the state of Connecticut. They use a platform called Connie. It's a health information exchange tool that has really been expanding with attention to the quality metrics and information sharing that like a health system, like a small clinic would have with a health system. We have care everywhere in Epic, but as you mentioned, most systems, the broad swath of us, a lot of us have Epic in the health system, but clearly that's incomplete. So a question just how we can simplify and how HITALK is approaching with attention to those quality metrics.
Yeah, I might call on Marta or somebody as part of this, but in general, you've hit on something really important, which is that regional health information exchange entities can do more than just exchanging information, and in different states or regions, they do that. We do have some here, but they just don't have that same function of sort of the quality or understanding or assessing value-based care. Instead, really trying to upskill the CCOs and in trying to do some of that. But that requires better interoperability between the systems, with agreements that are broader about how and where they can exchange and use that kind of crucial information and make sense of it, have the meaning be the same, which is what a regional health information exchange can help you do, like Connie or others. But that Oregon is in a different place than that. And that's actually something we've talked a lot about. What is the governance or part of health information exchange in achieving these kinds of goals? And I think we're open to the Health Policy Board about the direction you'd like to see that, or giving specific updates about where we see that. I don't know, Marta, if you have other thoughts about that.
Thanks, David. I think you raise a great point, and it has not specifically been an area of focus. So supporting value-based payment arrangements within the work that High Tech's done this year, but it is certainly something that's an ongoing conversation with the CCOs and information sharing that they do and the systems that they have implemented and how they support their contracted organizations. And also we get information from them about their systems and to what extent they're able to share the necessary information. We've also have some other conversations that are ongoing about how to ensure that organizations have the information they need in order to be able to even make the decision about whether or not to participate in a value-based payment arrangement. So it's ongoing work, and it's something that if the board has specific questions or concerns, we are happy to take those and address those further at a later date. Thank you.
Thank you, Team High Talk. I also, before we move on to our next committee, do want to acknowledge and appreciate that you had the impact of artificial intelligence on healthcare and especially the equity implications as part of your work plan. Really appreciate your team diving into that. We have a potentially narrow window to take state action in that area. And so thank you, High Talk, for your leadership and work. Specifically and broadly.
Thank you.
Thanks for joining us today. Okay, so our next committee up is the Health Equity Committee. We have co-chairs Beck Fox and Andy Walsh with us today. And you may begin a 5 to 7 minute presentation followed by 5 to 7 minutes of questions. Good morning, Andy. Begin when you're ready.
Good morning. This is Brenna. I'm one of the Health Equity Committee staff. Suzanne, it seems like I can't turn my video back on. It says it's been disabled. So, okie dokie, perfect. Hi, everybody. Now you can see my face so you know who's talking to you. I'm just here to set up our two co-chairs as they start. So if we can move to the next slide. Okay, perfect. So this is a little overview of what our current committee co-structure is. As I mentioned, my name is Brenna. I use she, her pronouns. I'm one of the OHA staff who helps to support the committee. And at this point, I'll turn it over to Andy and Beck to introduce themselves and get us started on our content.
Good morning. My name's Andy Walsh, she, her pronouns. I'm one of the co-chairs for the Health Equity Committee. I also work as a senior health policy advisor for the Children's Institute and live in Ontario in Eastern Oregon.
Good morning, everyone. Beck Fox, they, them pronouns. Apologies for being off camera this morning. It is very stormy here on the coast and my internet's a little shaky. I am a colleague of Andy's as a co-chair of the Health Equity Committee. And my role is also as member advocacy liaison at Intercommunity Health Network, CCO. Nice to be here.
Thanks, Beck and Andy. Can we go to the next slide?
Okay, great. So I'm gonna go over our 2025 activities for you all. We were really excited to have a really successful in-person retreat of several of our committee members at the Warm Springs Reservation in late October. It was a really successful retreat. It was really just very meaningful to be able to be present and build relationship with the tribe. And just really emphasize the HEC's commitment to tribal sovereignty and supporting healthy tribal communities. It helped inform how we think about working with the tribes in our work on the Equity Committee, and specifically, how do we ask all our presenters, how does this work impact the tribes? And so for example, I immediately thought like, oh, how does the Rural Health Transformation Grant impact the tribes? So that's something that I think was a really good eye-opener for us as a committee to really frame and be very intentional about how we're interacting and supporting the tribes. And it also really called attention to continuing our relationship building again with the tribal communities, and including invitations to events and building relationships not only with Warm Springs but the other tribes throughout Oregon as well. The second main update for 2025 is we've shifted in the last several months, been thinking a lot about just our member safety for the committee members as well as relationship building. So it includes some changes to how our meetings are structured moving forward. We're moving to bi-monthly public meetings. So the next 3 public meetings will be January 8th, March 12th, May 14th. And then in between, we'll have closed meetings that aren't about us making, decisions or voting on anything, but is really about relationship building. Again, this also came up with the retreat with the Warm Springs. And just really the importance of that community building and relationship building among committee members, and feeling like we have an opportunity to do that in a really respectful way. We're also been talking about moving to written meeting minutes rather than recordings posted on YouTube, as a potential safety mechanism as well for committee members. And then lastly, in terms of relationship building, we've heard also from our committee members directly that they've requested different things as well that we want to try and implement in 2026. So beginning meetings with more grounding and opening activities that are led by different HEC members, really giving each member an opportunity to highlight their own, themselves and their own work. Hosting meetings in person in different communities and locations across the state. It was really just a really tremendous opportunity to be able to travel to the Warm Springs reservation. And even for me in Ontario, it's nice to be able to see my colleagues, not just in the Portland area, but to really see all of our communities and get to share our communities with one another. And then identifying and calendaring community and service events to help boost those opportunities as well. And then I'll turn it to Brenna for the E&I leadership update.
Thank you so much, Andy. So I'm happy to share that E&I has welcomed 2 new leaders. There's a new division director, Dr. Stephen Nakana, who's been appointed the new permanent division director of OHA's Equity and Inclusion Division. He started about 2 weeks ago. Dr. Nakana has more than 15 years of leadership experience, most recently serving as Director of Community Health Partnerships, Metro for Care Oregon, and previously he's held leadership positions at Portland Community College, Portland General Electric, Port of Portland, and Mercy Corps. So far in these spaces where we've been sharing the news, we've learned that Dr. Nakana is a familiar name to many folks. So if that's the case, I hope you can help me in joining him with a warm welcome. Our team and our unit, which is the Equity and Policy Unit within E&I, has also welcomed a new director after Shelley Doss retired after many years of service. So we're welcoming Jemai Chapman, who joined in October. He came from a role with the Center for Healthcare Strategies, where he served as the Senior Program Officer, leading National Medicaid Policy and Equity Initiative. Previously, he also served as an executive of policy initiatives for Wisconsin's health department. So we just wanted to take a moment to name those 2 leadership changes, as both Dr. Nakana and Jemai are key folks in supporting the HEC and helping to ensure that the committee's recommendations are viewed, I think, with a level of seriousness and action by the agency as a whole. So with that, I'll pass it back to Beck, who's going to take us through the next slide.
You guys, Beck, if you could go through this slide quickly, please. We're just running a little tight on our window here. Thank you.
No problem. This should be a quick one. For 2026, we'll be working on some improved onboarding strategies, and we're really looking forward to welcoming a new membership slate in the first quarter of the year. The HEC has moved to rolling applications. Process-wise, that's been a bit more efficient than just opening them up and collecting applications just once a year. Doing them on a rolling basis seems to work better. The plan right now is to review those applicants and present a slate for appointment to OHPB in early 2026. So we are really excited to welcoming some new members to the Health Equity Committee. That should be great to get some new perspectives in there. We will also be aligning our strategic goals with the Oregon Health Policy Board's priorities, really continuing to work with you all in partnership. Super looking forward to that. We will be selecting equity-centered goals in support of and in alignment with OHPB's 2026 priority areas. And in particular, we are really looking forward to hearing more from you all on what your focus is within primary care and affordability are like. And within that specifically, really wanting to just make sure we're kind of honing in and paying specific intentional attention to ensuring that there is representation from people that are most affected by those issues. So for example, OHP members, folks that are underinsured, making sure that those perspectives and voices are included in conversations around affordability, and that the focus on primary care ensures including network adequacy for OHP members. So really looking forward to continued partnership and alignment, and I think there's some great opportunities for collaboration within that. And last, the HEC will be taking a look at our charter. It was last updated in 2023, so it's been a little while, and we'll be working to update that in 2026 to reflect the committee's current practices and approach. And I think that's it for this slide.
Yeah, so time for questions or conversation here.
Thank you, Team HEC. Brenda, go ahead.
Hi, this is Brenda Johnson. I want to thank you very much for your work. And my question is positioned around the power of what this committee can do in support of the board and the board's priorities. I'm struck by how health equity has been politicized, and we're facing the tension between public conversations around the importance of the body of work that you're carrying, mixed with safety and protections and boundaries for the people for whom are impacted. And so my orientation around and my concern is that the board lose traction for the sake of safety. So I suppose it's a bit of a position that and an encouragement to us as a board that we stay the course in supporting this committee's work, and that simply recognizing that the way in which the work is done is a bit different than how it may have been done more transparently in the past. So I wonder about how we can be in better of support of the committee, recognizing the climate that we're in and just acknowledging the fact that we may be signaling to the committee or to the environment more specifically that the work of health equity is somehow less important because we're not bringing it as transparently forward as perhaps we might have in the past. So that is a bunch of statements. There's a question that sits in it, which is specifically to you all about how we can stay the course, use this mechanism to speak publicly about the importance of health equity while also preserving the deeper work that you're doing within the committee. Do you have suggestions for us?
Yeah, thank you for all of that. And we agree, we've been actively struggling with that same tension for months now, and landed on this as really a pilot to see how this goes. It was really important as we discussed it was to make sure that anything that's time sensitive, perhaps that it doesn't, like you said, it doesn't actually impact work that needs to get done. And so not wanting to have to push things down. And so making sure there's mechanisms where we can pull together the committee in a public forum quickly if something urgent comes up. I don't know if Brenna or Rebecca, if you have specific suggestions. I think love to think through it and come back maybe to you all in the next co-chairs meetings to think through what that might look like. But I completely agree, and I feel very strongly that the work is more important than ever, and also feeling how important it is to really protect our committee members when we're seeing active attacks already happening against committee members in various settings. So it's a really, really challenging dynamic, and I don't have a good solution off the top of my head.
Thank you, Andy. I wonder if I could illustrate with a couple of examples, and I say this for the sake of concern that we may be losing traction on things like collection of REAL-D or SOGI data, or we may be losing traction because we haven't talked yet again about sort of the state's or the board's position on gender affirming care, and recognizing that in communities, those are under threat and under attack on the daily. And so I wonder how this board can be a bigger megaphone, a bigger microphone, I don't know, to be able to talk about the importance of the issues and help buffer against the fear or the threats that are sitting both at the committee or in communities. I just want, it's an invitation, I think, to all of us to consider how we continue to stay the course on the power of the work itself while we're in these volatile times. Otherwise, the ability to lose traction on some of the really meaningful work that we've put in play, we will simply be recovering for years and years. So it's, perhaps we turn to the committee to offer us recommendations about what we may be doing differently to support the work. Yeah.
That's that question. Yeah, I think that makes sense. I also wonder if there is a structure within OHA's strategic plan focused on health equity, where we could use that as set earlier, and use that as a structure to help us a checklist to make sure that we are not forgetting. And I think within that are some like specific gender affirming care adequacy questions. And so how do we continue? Yeah, stay the course. Stay the course. Thank you.
I was gonna say, I will say, I think as we look through our charter update as well, that'll provide a really good opportunity for not only as we review it, but also to then work with you all on thinking through how we can make sure we're still extremely effective while facing the reality of the climate we're in.
Yes, that's great. Thank you, Andy. Thank you, Beck. Thank you, Brenna. Thank you, Team Health Equity Committee. Okay. Next up will be Metrics and Scoring Committee with Jorge Ramirez, who is here in person. Thank you for joining us, Jorge.
I wrote the atmospheric river. It's quite something. Thanks for the opportunity to be here. Jorge Ramirez Garcia, pronouns female. And I've had the honor to vice chair and co-chair the Metrics and Scoring Committee during the post-pandemic era. It's good to be back with you. I was co-chair the Health Equity Committee during the pre-pandemic and pandemic transparent era, as it was called. So I'm glad to be here with you. We try to balance giving a lot of information for all of you, but I will abbreviate and then you can look at the slides. So we can start with the first one. We have one big, huge deliverable every year, which is a set of measures, quality healthcare measures, with quality incentive programs for each of the measures. That's basically what we do. Every year, we start to surely charged committee with 9 seats. 3 are CCOs, 3 are measurement experts, and 3 community at large members. We are also in the process in 2026 to update our bylaws and our community charter. Next slide, please. It's important from my perspective, to highlight that our committee and work, it is really part of healthcare transformation. It is a really vibrant part of healthcare transformation that started more than a decade ago and went through 1.0 and 2.0. And so it is designed to incentivize population health improvement through quality healthcare measures, through bonus dollars. That's the design. So on top of the actuarially sound rates, then there is an additional bonus funds that would incentivize these measures. I mean, it is a lot of dollars, but it is also high stakes because of the quality performance measures. Next slide, please. We have a real broad spectrum of care charge, starting among all the levers of value-based healthcare. This is, I would say, a pretty comprehensive population health lever, because we are very comprehensive on health. Traditionally, from the neck down, physical healthcare, we cover that, and we cover that across the spectrum of care, from primary care access and prevention to care of acute and chronic conditions, and in between secondary prevention. We cover the entire life course because we are aligned with the CMS, Centers for Medicaid and Medicare course set. So from 0.99 years to 64 and sometimes beyond, we cover the whole spectrum. And a lot of touch points on the surface points, in the whole spectrum of care. Next slide, please. So we have been working post-pandemic since the legislative year 2023 with the Senate Bill 966 statute that really provided us an opportunity to be really responsive to the state of Oregon and priorities. Leading with mitigating health inequities. So we have the charge to improve population health, but also to mitigate gaps between health equity priority populations in an inclusive manner, because it is a program for the entire state's population health. So to do so, we're providing the opportunity to have a set of metrics called upstream metrics in the bill, but basically to address metrics that would mitigate health inequities by addressing social determinants of health, which we have one clear example here in front of you, but I would argue also other state health priorities, and I will illustrate that when I review with you the entire set. We are, of course, aligned with the CMS score set, and these measures are called downstream in this piece of legislation. Next slide, please. And we do have 4 that are, required, or we're told you should use these 4, but we have more than 4 for good reason, and I can elaborate with that time permitted. Next slide, please. So to mitigate health inequities, one mechanism is, we might need different measures that are on the core set. So again, upstream measures. But I mean, this model reminds us that we had to identify the gaps, the health inequities. And then the end game is to incentivize, that last blue. We have to incentivize mitigating those health inequities. And in between, of course, we implement interventions and we invest in the development of measures. Now, so we have other things to do other than choosing measures that might, reflect health inequities. And basically here we have a couple of examples. There have been a lot of developments, but we're going to highlight a couple of them here. It has to do with the workflow of identifying those health equity populations, again, in an inclusive manner for the entire state. And we've had a lot of progress in building up the infrastructure to collect race, ethnicity, language data, real data, and SOGI, actually sexual orientation, gender identity. A lot of great development in the last few years post-pandemic in terms of building those data infrastructure. And another question is, how do we continue that work? Because to mitigate those health inequities, we gotta have the reliable, sound data. And back to your comment, that needs to be prioritized. So those are 2 examples of other developments, identifying the health inequity measures and flagging what are the health status metrics in which there are huge gaps. If we're going to invest in mitigating gaps, well, let's start with the important ones and not just go and do it in every measure that there is, right? So we've had strides and work in progress to flag health disparity sensitive measures, and then a lot of work on the building infrastructure of data to do so. Next slide, please. So the next slide is, we have an annual program, really well structured. On Q1, we do formative work and then end up with an initial measure set guidance. And then we work through each quarter in drafting the measure set. And a couple important pieces here of information are that it is participatory because the committee receives a series of 3 surveys that allows us to go through the information and weigh in. And then we build drafting so that at a committee meeting we draft and there's time for stakeholders before finalizing. There's 1 month at least, if not 2, for stakeholders to know our work and weigh in before we finalize those measures and incentive metrics. Next slide, please. So as we need to close in time here, we do have 12 measures, and it is we started in CCO 1.0 with 3,000 measures. We're down to 2,000. It is the smallest set of measures we've ever had. Another development is that for setting improvement targets, we have the benchmarks, but we have a protection for the healthcare organizations so that if they're too far away from the benchmark, they just cover 1/10 of the distance and then they meet the benchmark. But then we have a protection for the population. That's the way I see it, which is a floor. When organizations are super close or kind of close, that 10% distance can be less than a percentage point. So then the population health improvement kind of, gets a little bit stuck. So that's the second protection for the population, the improvement target floor. So another development in this measure set is that the committee decided to do away with some floors for the first time in its history of the measurement program, to my knowledge, and I stand to be corrected. My colleagues should be on the line in OHA Health Analytics. But we do cover a lot of ground. We have, for your interest, primary care measures and preventive care, maternal and perinatal health. In the next slide, we're going to go back to the concept of from the neck up, we have behavioral health measures, 2 very strong behavioral health measures. And a measure for healthcare of acute and chronic conditions. These are on our adult core set, and these are measures that highlight the value of the quality health program, not just the dollars to provide the service, but these types of measures are meant to increase the capacity of the healthcare system and prevent really costly care. Because in these conditions, we have emergency departments, we have amputations, we have all kinds of super costly care. So these measures are really meant to drive the population health improvements and save a lot of costs, which, as you know, is going to become increasingly important during this era of lower finances. Next slide, please. We have, we're going to wrap up the set so that and give you time for questions. The upstream, these are the ones that are Oregon home developed or adapted. And we do have a couple of important points here about these measures is the investment of the state of Oregon in these measures. We're talking about a 7-year investment because there's always like committees to develop the metric through a stakeholder participation. And there's about a 3 to 5 year glide path in which the measure gets implemented through a stage-wide process. Then you end up into, okay, now we're ready to calculate rates and drive population health improvement. So something for us to keep our eyes on, and I would say uplift as 2027 approaches fast, is to keep these measures, keep this investment. We're like 80% there. Do we want to give up on an investment that is 80% there? I would say no. We need to keep to see these measures come alive and do what they're supposed to do, address linguistic assistance, the health equity measure in an inclusive manner. It is linguistic assistance for people who are deaf or blind, and then also for people with linguistic issues or needs. We have, of course, social needs screening And really, really important, the kindergarten readiness prioritization that we carry from CCO 1.0. We developed a gem of a measure also here in the state of Oregon. The Young Children Social Emotional Issue Intervention Treatment Services measure that again addresses that pre-kindergarten readiness, and it is a behavioral health measure. We are prioritizing preventive dental and oral health services for kindergarten readiness, and also for adult teeth. Not quite for adults, but adult teeth. So after the teeth turnover, we decided as a committee, well, we should do it for youth. So let's wrap up. Sorry about the time extension here, but in summary, we have the fewest set of measures ever. With the first time, we don't have those floors. And next slide, please. And we're going to continue on our effort to mitigate health inequities. There is a lot of work that has been taking place to proactively design how do we benchmark, how do we incentivize the reduction of a difference, which is a mathematical but also multiple stakeholder and political act also in the positive sense of the word. So we need to mitigate and do a good benchmarking model of mitigating health inequities. We can talk about that when there's more time.
We are ready.
I think that wraps it up.
Great. Thank you, Jorge. We are ready. Are there any questions for Jorge and for our committee? Hello, Hayden.
Yeah, Hayden Ripley. One high-level question that maybe, if this is not the right, I'm happy to table it. Just as somebody who's new here, I did want to ask the high-level question. Again, can do it another time about sort of the state's view on and kind of interpretation of the success of these programs. There's been in the literature, I think, a lot of concern that for the last 20 years through Medicare and Medicaid, commercial payers, there's been quite a push towards pay for performance, P for P. And I think it's fair to characterize the literature as underwhelming on this front, and a question as to whether paying for these metrics actually improves health outcomes, improves the experience of care, and lowers cost. And so I'm curious about the state's perspective in terms of these specific programs, and essentially whether the view is that these programs, I guess to put it at the highest level, are working, and the level of confidence that we're seeing that these extensive P for P performance in Medicaid is driving, is actually achieving the goals that are intended. So I just want to put that question out there. Again, happy to take it up in any sort of forum.
I can just provide 2 cents. It's a really important question. The quality strategy is really critical. How do we pay for value rather than fee for service? And does it work? Right. And I'm familiar with the mixed evidence. I do remind us that we have Oregon data. We have during 1.0 and the first waiver, a midterm evaluation conducted for our program and an impact evaluation. And we know that when we implement these measures, the performance drops. And we know when those measures come live in this program, they rise. And our colleagues have seen that, who manage all these dashboards, and we've gone through the implemented measures, and you can probably find data now about the recent measures that have been dropped, and identify the drop in performance. There's more to that, of course. And I will acknowledge that this is a presentation with my colleagues at OHPB Analytics, by the way. They did all this fabulous work. I just get to come here and talk about it. Yes.
All right, one last short
Perfect.
question, short answer.
Just, observation, just we talked about earlier about technology and the reporting and the army that takes place for the reporting mechanism of this. And I think the movement towards the core sets is ideal. But just want to encourage, kind of the committee thinking about the simplicity of choosing those and what the body of work that takes place for a smaller clinic. Like if I think of a smaller independent clinic versus a health system like Legacy or Kaiser, that's a different entity that can do that body of work. So just to encourage us to think about that. And I think the other question about research and data is the intervention, is that leading to the outcomes we want? And it sounds like we have some of that, but I wonder about that in your guys' body of work, to choose that and the reflection that takes place, whether that's a year out, 2 years, usually it's like probably 3 years out to see, and the feedback mechanism say, did we choose the right metric and did we want to see that outcome? So I'm just curious, not to answer here, but in future presentations, a little bit to Hayden's question, what are we getting for that intervention?
Yeah, and to answer, but it is evaluation 101, right? That when you implement something, policymakers want the result right away, and it usually takes time for that to develop. But I will add my 2 cents, not as an answer, but as a point of discussion, that part of the value of this is to uplift the healthcare system capacity, but the measurement capacity, right? And I came a couple of minutes late for your first panel, but the movement in CMS is to move toward electronic clinical data systems that provide that capacity. And now we have, because it is burdensome and it takes work, we do have kind of a pull to go back to claims, which are administrative data and not our complex data healthcare systems that can really tie records, electronic health records and various sources in the way that we should. So we have to keep an eye on the woes of the financial pressures, not, in my humble opinion, not setting us back to rely only on administrative data and not move our state forward in its healthcare measurement capacity.
Thank you so much, Jorge, for joining us in person. And thank you for the tremendous body of work that the Metrics and Scoring Committee does. It's a very robust participatory committee, both for members and the public.
It is a community doing all this work. I just got to talk about it.
Okay, I'm going to speed read our public comment introduction, and then we're moving to public comment, but we are running quite late, so here we go. The Oregon Health Policy Board welcomes and deeply public testimony. It's one of our most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject or correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual, not the representation of the Health Policy Board nor OHA. Each presenter is given 2 minutes to share. In the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll have a 2-minute timer for each commenter, and we kindly ask that you conclude your presentation when the timer is complete. Please know that written and verbal comments will be reviewed and discussed following each meeting by the board chairs and staff to determine appropriate next steps. First up in public comment, we'll hear from Courtney Johnston, Government Relations at Trillium. Courtney, front and center, begin when you're ready. And after that, we'll move to Henry.
Okay, thank you. Thank you for the introduction. I'm here today to talk about the importance of the Quality Incentive Program, which you just heard about, and the impacts of the reduction in incentive funding for the OHA has made to the 2025 plan year. Oregon's CCO model created a reimbursement program that aimed to improve care quality and reduce costs by linking payments to performance. Because the full withhold is at risk, CCOs assume financial responsibility for our members, but that incentivizes us to help clinics and provider partners improve performance on evidence-based quality metrics. This serves as the linchpin of the CCO model. It ensures that both the CCO and our provider partners are sharing in the risk and reward of achieving better health outcomes for Oregon Health Plan members. Reducing this funding while at the same time these metrics are becoming more complicated and more multifaceted. You did hear that there are less, but the information required has increased tremendously over time. This will not only erode the CCO provider partnerships that have been forged, it will defund important population health programs such as dental sealant programs that are only made possible through this funding. But importantly, decreasing this funding will result in reduced access to care for some of our most vulnerable members. At this time of unprecedented financial challenges, this funding model can be the mechanism that allows providers to see Medicaid members. This will put providers in a position to have to adapt their approaches and business models, increasing the difficulty in achieving future metrics and contribute to a loss in the progress we have made to transform the delivery system. As you embark on your primary care strategy work, you have an opportunity to improve on this model, to double down on what we know is working, look at the evidence, to ensure our provider community remains viable and our members can access that care they need. We are asking you for your support in looking at this pivotal part of our Medicaid program and to refocus quality of care as an imperative of this model. Thank you for your time today.
Thank you, Courtney. Henry O'Keefe, welcome you up next, followed by Sierra Canfield. Henry, are you with us?
Yes, thank you. And sorry, I'm not on camera. The software is telling me that it, can I start I can start the video. Wonderful. Okay, good morning, Chair Isaacson and members of the Health Policy Board. My name is Henry O'Keefe. I use he, him pronouns, and I am the Vice President of Healthcare Policy at the PacWest Lobby Group. I am here today on behalf of my client, the Coalition for a Healthy Oregon. My purpose today is to urge you to support fully funding the Coordinated Care Organization Quality Incentive Program. The key point is simple. These dollars are not a bonus. They are a withhold already built into the CCO rate that the legislature has approved. When that withhold is reduced, it doesn't trim extra. It cuts the budget CCOs and provider partners rely on to deliver care and to improve outcomes. Are they perfect? No, but they are working. Over the last 7 years, Oregon has seen real measurable improvements across populations. For example, prenatal and postpartum care for Black and African American Oregonians has increased from 55.8% in 2018 to 80.8% this year, up 25 points. And tobacco use among Hispanic and Latino adults has dropped from 16.8% to 8.4% in 2024. That means it's cut in half. Those outcomes did not happen by accident. They reflect sustained, targeted investments driven by the quality pool. So our request is straightforward. Please support fully funding the Quality Incentive Program for 2026. Protect what's working and don't risk reversing hard-won progress. Thank you.
Thank you, Henry. Sierra Canfield, turn to you next. And we'll follow with Marianne. Sierra, begin when you're ready.
Good morning. My name is Sierra Canfield, Director of Public Policy for the Hospital Association of Oregon. Thank you for the opportunity to provide public comment. The Hospital Association's comments today focus on the Oregon Health Policy Board's directions to the newly created Affordability Committee. The board has appropriately acknowledged that an important question in the affordability conversation is affordability for whom? We appreciate that the board acknowledged that one of the key questions is, can we afford to deliver care? However, we are concerned that the board has taken the position that it would like the Affordability Committee to focus on other questions instead of that key question. The cost to deliver care is a critical component of the cost for employers, purchasers, consumers, and households. Earlier this year, the Hospital Association released the Oregon Hospitals on the Brink report, which explains that hospitals' costs to provide care are rising steeply. Payments to hospitals do not cover the costs of providing care, and Oregon's regulatory environment is complex and costly. The Hospital Association urges the board and the Affordability Committee to review the Oregon Hospitals on the Brink report. Since the report was issued, the healthcare landscape in the state has continued to worsen. Oregon's healthcare system is in crisis now, and the federal changes in H.R. 1 will serve as an accelerant. This is a defining moment for healthcare in Oregon. We encourage the board to consider the cost to deliver care in this state. My testimony on the record includes a link to the report as well as a full copy of the PDF. Thank you.
Thank you, Sierra. Marianne Cooper, I see you on screen, and then we'll follow with Matt Prokop.
Thank you, and good morning, members of the Oregon Health Policy Board. My name is Marianne Cooper, and I am the Director of Government Relations for Regents Blue Cross Blue Shield of Oregon. Regents has been a longtime member of the Primary Care Payment Reform Collaborative and has been involved in several different streams of work around primary care access in the state. We appreciate the opportunity to review the proposed work plan for the Primary Care Strategy Committee and appreciate the thoughtful approach to establishing this important initiative. Primary care serves as a cornerstone of our healthcare system. We all know it provides patients with their first point of access to care, plays a critical role in care coordination, and helps reduce utilization of more expensive services. Primary care providers are essential members of the care team, and their contributions cannot be overstated. We are committed to improving access to primary care and have several initiatives within Regents working on this goal. While we support the committee's objectives, we have concerns about the stakeholder representation outlined in Section 4. The proposed composition allocates at least 8 seats to primary care providers and their professional associations, while limiting healthcare payers to just 2 seats and purchasers and employers to 1 seat. This structure appears to be overrepresentative of primary care providers and related industries, while underrepresentative of payer and purchaser perspectives. Given that one of the primary issues raised in the primary care access conversation is developing strategies that directly impact payment models and resource allocation, balanced representation is essential to ensure all viewpoints are adequately considered. We recommend that the committee membership selection process be explicitly changed to ensure robust payer representation, including additional health plans within each line of business in the state. This balanced approach will strengthen the committee's ability to develop sustainable, equitable strategies that serve all stakeholders in Oregon's healthcare system. Thank you so much.
Thank you, Marianne. Matt Prokop, begin when you're ready.
Alrighty, thank you for the opportunity to provide public comments today. My name is Matt Prokop, and I'm the Director of State Government Affairs for the Northwest and North Central region for the American Diabetes Association. As the Oregon Health Policy Board works to develop strategies to implement policies that provide access to quality, affordable health care for all Oregonians, we wanted to highlight current barriers in Medicaid on access to continuous glucose monitors. Continuous glucose monitors are wearable devices that provide frequent readings of glucose levels throughout the day. The readings help the person with diabetes self-manage their glucose levels so they can avoid short-term complications brought on by glucose levels being too high or low, and improved glycemic management to reduce the risk of long-term complications from diabetes. Utilization controls and restrictive coverage policies sometimes prevent these devices from being accessible to individuals who benefit from them. To ensure appropriate access to CGMs, ADA advocates for elimination of overly restrictive barriers to better align with ADA's standards of care in diabetes. This includes a recommendation that CGM should be accessible for diabetes management to youth and adults with diabetes on any type of insulin therapy. Current criteria in Oregon does not allow all insulin users access to these life-saving devices. For example, for those living with type 2 or gestational diabetes, access to CGM is permitted only for those on short or intermediate-acting insulins. Additionally, current Medicaid requirements include access limitations tied to a lab test referred to as an A1C, which are unnecessary and do not align with ADA's clinical guidelines, Medicare's criteria, nor many other states' criteria. A majority of states from across the country have aligned with Medicare coverage criteria for CGMs and the American Diabetes Association standards of care. We appreciate the Oregon Policy Board's continued work on issues related to diabetes management and care, and happy to provide additional information as you work moving forward. Thank you for the opportunity today.
Thank you, Matt. Okay. people have signed up, but since we are in person today, I want to make sure that there aren't any additional ones in the room. I want to acknowledge that Melina Moran, board member, has joined us. Thank you, Melina. We're going to take a quick break. And also want to introduce Brooke Emery, the new ombuds person here in person. So hello and welcome to your new role, Brooke.
Very excited to be here. Thank you.
And with that, we'll take a 5-minute break. So sorry, it's short. Gotta make it 10. I'm sorry, ombuds team not here.
Yes, yes, but in the event that.
But yes,
Members
testimony.
is always, yeah, don't hesitate.
Okay, we're just gonna keep going here. I am deeply apologetic, but I don't.
Doing a good job.
That's what happens when we're running 15 minutes
Train
late.
going.
Okay, so, are we unmuted? Can Melina, can you hear us? Excellent, great. Okay, so welcome back from break, everyone. I'd like to welcome Brenda Johnson and Melina Moran, who have been working with staff behind the scenes on the new primary care strategy committee. When we first reviewed and supported the idea of the committee at our October retreat, received a progress update at our last meeting. We're reconvening today to review draft charter, framework, and work plans. So thank you, Brenda and Melina, for your dedication. Take it away.
Thank you. It's been a privilege, and I just really want to first start off by acknowledging Melina and our partnership, and also the remarkable OHPB staff who have helped put together the materials for today. It's, as you can tell, a culmination of a lot of strategic thinking, a lot of inclusion, and what we heard as we evaluated CCO 3.0 from communities about the importance of primary care and access to care. And like taking that kind of through line to today's decision couldn't be underestimated if we didn't have the support from Claire, Chris, Summer, Amy. You know, I think about Suzanne, Alicia too, who have been really useful and helpful in helping us kind of steer the course and set us up over today. The outcome of the time that we aim to spend today is to achieve your support and approval on the charter document. I think that is the main deliverable or action item for today. It is supported by two documents that are in your packet. One is the slideshow that's on the screen here, which is just to orient you to the framework that we've been using. And then the work plan is a draft. It doesn't really require your approval today, but it's intended to help spur conversation about what we think this new committee could be focusing its early work on. So without further comment, I think I'll just point us to the 4 slides that we have in your packet today. The first of which is to reframe the policy primary care strategy committee framework itself. Recognizing, I'll start with just reading the vision statement that's on the screen. That Oregon envisions a sustainable and fully supported primary care system where every person has access to whole person care that fosters well-being, strengthens communities, uplifts care teams, advances equity, and keeps healthcare. In this framework itself, you see 3 intersecting component parts that really serve as a foundation of the committee's work as we envision it. The first being an intersection between the body of work in the workforce, the delivery system, the models of care, the types of care that we provide, and evaluation and support for programs that help incent and organize the delivery system itself. And then the payment and affordability portion of primary care and a deeper dive and evaluation, both learning from important work that has happened in the past, the Primary Care Payment Reform Collaborative, one of many bodies that have really helped inform, but hasn't yet completely aligned in all intersection parts of the model itself. In the center of this is a proposed focus for the committee's work, which are to propose to this board strategies that strengthen access to equitable, affordable, and quality primary care. The next slide. I'll start with workforce, and then perhaps Melina, you can pick up on the delivery system slide, and we'll just kind of toggle back and forth. Does that work for you, Melina? Okay, great. So really critical to the conversation of primary care is you can't deliver a highly functioning system of care without really adequately trained and well-supported primary care providers and care team members who help make this work possible. We have our healthcare workforce committee that is organized and focused in part by its work in support of primary care, and it's also focused on areas in the healthcare ecosystem that extend beyond primary care. So the intersectionality between these parts of the system, again, these bullet points are proposed to give you sort of a landscape review of types of topics that the committee could be integrating alongside our healthcare workforce committee. Topics like, do we have adequate training and education, career pathways planned? Are we spending time and attention to reducing barriers on administrative demands that get in the way of providing high quality care within the clinical settings in the healthcare system overall? How do we think about prioritizing the work around provider wellness and resiliency and the structural drivers of burnout that are plaguing and frankly crushing primary care in our day-to-day experiences? The body of work that really addresses the importance of provider diversity, and also kind of paying attention to how misaligned incentives across payers can create additional complexity and burden within the workforce itself. Melina, why don't we do next slide for you?
So the next circle here is the delivery system, and this is the next part to the strategies to improving primary care. So this part is important, and these are examples of delivery systems. So the care models would be something to look at, such as primary-centered primary care homes, or patient-centered primary care homes, excuse me, team-based care, integrated behavioral health, and integrated oral health are not mutually exclusive. Also, enabling systems such as electronic health records, health information technology, health information exchange, and community information exchanges. We know these are very important in order to give quality care for all.
Thanks,
And
Melina.
like I said, this is not exclusive. Yep. And Brenda, the next slide.
Thank you. Of course, we couldn't be thinking about, how important it is to stabilize and strengthen a primary care system if we didn't also consider the structural alignment around payment and affordability. We've got an intersection between our Committee on Healthcare Affordability, that is, the oversight and purview of this board, and recognizing how payment and types of incentives within the primary care system can create a more affordable healthcare ecosystem writ large. So the idea around the body of work kind of connecting in this particular domain is about how we measure and report the primary care spend, how we think about payment models such as value-based pay, quality incentive models, as was discussed earlier today, both in public testimony as in our earlier committee presentations, levels of payment, and thinking about how, the healthcare payment and financial ecosystem is impacted by lack of investment in primary care when we think about other acute care or more costly settings. So recognizing things around like how much we influence what happens in specialty care, in departments and hospitalizations, et cetera. So this important section of primary care and its relationship to payment. I think that's it on the slide deck itself. Just to, I'm trying to go fast to help us support the time constraints of the committee. And I'll turn your attention to the board materials where we have our draft charter prepared for you. Again, this is informed by a lot of this board's focus and conversation, as well as our October strategic planning retreat. Your comments and feedback hopefully have been reflected in the charter itself in terms of the recommendations for our organizing principles. And really setting, as this board determined that affordability and primary care are our number 1 and 2 priorities for the board's work in 2026, that this is like a way to jumpstart that particular initiative and that particular board priority by focusing and giving really deliberate direction to a new committee to help take the board's work and charge and already use a lot of expertise that is in the ecosystem of primary care, organizing it to come prepared to give you recommendations for, in concert with the Oregon Health Authority Government Relations team, to give you recommendations for policy options, legislative concepts that could be advanced that align with this board's priority. So I'll pause here. Melina, do you have more to say about the charter itself before we entertain questions that might come from the board about what's been presented so far? Anything else? Okay. Great. So maybe we could just turn it to discussion right away to see, is there anything in the charter from your perspective that deserves some time, attention, some strengthening, questions? Go ahead, Phil.
Thanks, Ray. This is tremendous work. And clearly a lot of thought has gone into this and the expertise that you all bring and the input you've gotten. I really like the vision that this is focused on patients and consumers and communities. That goal of every person has access to whole person care, and so on, and under the purpose, strengthening access to equitable, affordable, high quality patient care. The means to doing that is by strengthening the delivery system, understand workforce and payment and so on. And I just want to make sure that as we move forward, that the patient and consumer focus stays central to this, so that we don't just focus on the delivery system, how care is delivered, but we want to make sure we're understanding how care is received or how access to care is enabled and quality and equity is achieved. Along those lines, the one of the proposed committee, it does seem that the patient and purchaser and payer perspective is underrepresented. This is some of you may know, an issue that I raise in many with many committees. Clearly, we need the expertise of primary care providers and health systems and the specialists, health center administration, so on. I can understand why that expertise is important. I like to raise the question of whether we want to balance this more to have a stronger voice for consumers, purchasers, and payers, who I think, well, consumers and patients are the ultimate receivers, but purchasers obviously play a very important role, and payers do as well in achieving what we're trying to.
Great question. Yeah. I can talk a little bit about the deliberations from the work group and then turn it back to this group, I think, for future consideration. Primary care, unlike other groups, by and large struggles with its representation in and of itself as a delivery system. And this isn't to suggest that what you're sharing is not really critically important to the ultimate focus of who is benefiting from an organized delivery system that's really high quality are the very consumers that we're intended to serve. So keeping that first and foremost in all of our minds, I couldn't agree with you more. The question that comes into play, as we heard like in the public testimony, is who gets to decide what that looks like, where we think about where payment, where workforce, and where the delivery system itself is intersecting with one another on behalf of the people that we serve. So the composition was a big topic of our work group, and thinking like this is going to be a really important committee to belong to. Its function is intended to gather input from other constituency groups and bring it back to the forum to be able to ensure that voices are well represented. So in my estimation, this is just a personal opinion, it would be really hard to dedicate like the perfect ideal structure that would ensure that all voices are heard in exactly the same proportion of one another. And that the committee composition itself is going to be really important to set the agenda such that those voices that may not be represented in the room itself, so the health insurance plan that doesn't have a seat at that table is still included in the process, that the consumers are included in the process, that the providers are included in the process overall. So I think the organizing principles of where the scope of the committee is actually set is really important to say, this is the outcome that this board is actually asking for. And the process of inclusion is done. I keep drawing these figures in my mind, or as you can see my hands, it's about of it in and out. Like, how do we know that purchasers have been included in what their needs are? And most importantly, that they're recommending solutions to the committee to therefore bring to the board. There's no question that people have plenty of time, energy, and effort to sit on the problem itself. In fact, many of the state's policy committees and work groups and task force have struggled because we'll sit on the issues without recommending strategies that really help improve the issues overall. So to speak bluntly, we'll spend a lot of time cultivating and recultivating and talking about how hard it is without popping out to find options for groups to really consider and to move an agenda forward. So the composition was built with that in mind. The people who are at the affect of the crush of the primary care system overall and the expectations are the provider types that are sitting in it and working in it every single day. So it's not to make their voice more or less important than anyone else's voice, but there isn't a venue necessarily that organizes that conversation yet. So that's my response to your point. It's kind of
I understand the idea of gathering info from others who are not in the room. But it seems to me people who are in the room, they're the ones who are gathering or who are chewing over this information.
That's right.
And are ultimately making recommendations. And it seems to me who's in the room is important. And I am continued while gathering information from others who are not in the room is great. It should be done. Not everybody can be in the room. Who is in the room makes a difference.
Yeah.
And I believe that there are sometimes solutions that are developed. Solution orientation is great. Solutions that are developed by one group sometimes can be better, can be improved by having solutions brought by others that might bring a different perspective. And so a patient might say, like, you know, what would really work for me is XYZ. And so that kind of solution would be better than what you're all thinking about from inside the delivery system. So I continue to express interest or express a preference for having greater representation of patients, consumers, as well as purchasers and payers in the group, so that there's that perspective is in the room, not just gathered from outside.
Yeah, thank you. Hayden, go ahead.
Hayden Rickley here. Question and a comment or two, and thanks for all this work. And another caveat here, some of my questions might be elementary. The first is, and I'll just go through them and you can respond to any of them or all of them. First on question on whether the group has considered the ownership landscape of primary care. And when we think about questions of burnout or questions of access, the healthcare delivery system generally, and specifically in primary care, is changing rapidly with continued growth of hospital systems generally, with the growth of non-hospital corporate entities coming into owning physician practices. This has happened in Oregon, it's happening nationwide. Curious how those questions fit into this body's work. Second is probably more of a comment as we think about framing the work. I think it would be useful to push on this question about the interaction between affordability and primary care. Here again, I think there's a real question as to what role primary care should play in achieving a healthcare system's goal of costs. And it is my position that achieving certain goals in primary care aren't necessarily going to reduce costs in the healthcare system. And I think oftentimes there are assumptions made in health policy discourse about the connection between investing in primary care and reducing total system costs. I think that's a really important question to think about going about this work. Again, thinking there might be certain things we want to achieve in the primary care system that are going to produce downstream costs in the system. And that, of course, is a values call as to whether you want to do that. But I think there's often an assumption that primary care investment is going to reduce total system cost. And here, I think the literature is very shaky on that question. I think it's worth considering. And then the third is just, obviously, we're dealing in a multi-payer system. We're dealing at the state levels, so many federal rules. As we go about thinking through this and ultimately wanting to get to a policy solution, I would encourage trying to think about those legal and policy questions ahead of time in terms of what's achievable. When we think about alignment across payers, for example, there are a lot of barriers in terms of the state being able to, pass a bill and do that. And that implicates a whole bunch of different bodies of state and federal law. And I think that's useful to think about ahead of time when approaching these efforts.
Yeah. That's great. I'll just kind of riff to the extent that the group or the subgroup has had some of those conversations. Certainly not an unfamiliar set of kind of criteria to the body of work, and it's a perfect illustration in my mind of the types of conversations that we could task the committee to consider. So when we think about the structure of this committee reporting to this board, and your question earlier about inclusion and oversight and who sits on the committee and all of that, at the purview of this board, influencing and setting the committee's strategic intention is really an important early body of work that we think will set the committee up for success. So for example, in the work plan itself, we're asking the committee to already come pre-prepared with legislative concepts that have already been built out in the ether but haven't yet been actualized. Or we can be thinking about the alignment with the government affairs team, which is a really deliberate move to make sure that there are placeholders for legislative concepts that this committee will be able to nest into. This board will have the oversight of all of that work. So the intention about like both the composition question, Bill, to your earlier comment, who sits in the room, you all are sitting in a room by which you can help influence and help steer and guide the committee to the most important questions we're asking it to take hold and chew on, bring back to this board for deliberation and recommendations. So I'm kind of with you, Hayden, in the idea that those presuppositions about what affordability is and isn't, and what primary care's role and relationship is to affordability, that's such a great existential question that the committee could digest, look at, kind of competing intentions like the discourse and where the arguments sit in that field of study. Nevertheless, bring forward, this is our best thinking at the time in terms of how we can grapple with the current percentage of primary care spend relative to the whole total healthcare spend, which vacillates around the 12%. Right? Or arguably, why not 15 or et cetera. But, smart people, and I have been so impressed with OHA's committee structure. We heard a lot about it from other committees today, and this board's committee structure of recruiting exceptional talent to these conversations and really smart, wickedly smart people who can help inform and then bring back to this board their best thinking, and you all then setting, this is where we think we ought to go. But I'll turn to Melina. Melina, do you have anything else that you're thinking of as you listen to so far the two board questions that have come up?
No, I think that you're spot on that these are examples of conversations that will be had in this new committee. And this work has been being done in all parts of Oregon, and this committee is being created to align that work. And it's just so important. And I just I do want to take a moment to thank the OHA staff and Brenda. And since I do have the floor for a second, I won't be here at the end of the meeting. So Brenda, I do want to thank you for the work that you have done and on the board and with this project, and your time on the board and your volunteer time and all your years and commitment. And you've been a mentor to me through this process for me. So I just want to take a moment and say thank you.
Thanks.
Yeah. With this charter, I hope the board will vote yes. We did put a lot of time and effort, and staff is really thorough and supportive, and yeah, I don't have really anything else to add, but these conversations are just great examples of what this committee will be working on.
Go ahead, Tony.
Yeah, Tony German. Well, first off, I am just so thrilled as a board us to be focused on this as a priority, and a great deal of gratitude to Melina and Brenda and their charge and picking up this baton and doing a great deal of work, and extension to all the OHA staff. I mean, I think this is a great body of work. And I think the questions that have come forward are really important. I just wanted to reflect on some of my thoughts from the space I sit in primary care and serving that role for a while. What I would observe over the last several years being in primary care for the last 15 years in this state is that we have a number of different initiatives, a number of pieces of legislation that are all really excellent directives and thoughtfulness, and to achieve what we want to see really is the patient experience and quality of care, cost reductions, but ultimately we really want to see good health. Right? And the foundation of a good health system is really the bedrock of primary care. And we have strained primary care extensively as we've brought forward testimony to this board. And we just know that it is a perennial problem as far as ensuring the integrity of how we're supporting primary care, both on the payment side, the workforce. I think the three areas that were demonstrated above are really the key characteristics, but it's the coordination and the strategy. And there has not been clarity in our state, I think, that has brought those together. And I'll just illustrate an example of our topics today. We feel that we want to ensure payment produces quality versus value-based care, but we're not entirely seeing what the impact is on the workforce itself. We're not really paying attention to how we efficiently report that or how we acquire that data. I think an entity of this nature, and I was really excited to contribute to the charter and join in on some of those conversations, to see that, the bullet items we have here, is the statewide goal is what we want for primary care, how we coordinate initiatives. And I think that's a key characteristic, which I think the value is in this primary care strategy committee, right? That it can have the connection of existing work that's taking place. But again, we find ourselves in silos. And I think we need to break down those walls to say, hey, how can high talk, how can the healthcare workforce, how can primary care, how can the community affordability come together to create cohesion and simplify a system that is overly burdensome? We know it's a perennial problem to recruit, and there is a lot of people leaving primary care, which we have illustrated by testimony in this committee. And I think that we can really have some focused inroads. To the question of the composure of the group, I think it's a valid question. I think on the primary care patient center primary care payment reform collaborative, there were a great deal of insurers on that group and payers. And I think there still will be a connection from that group as it transitions to this entity. Right. So I think that will still be a support for the construct that we're trying to get good feedback from those. But I really appreciate the attention. It is a very large group. 18 members is a big group to create policy on. And I think we'll see a lot of contributions. I'm looking forward to a number of the areas that I've been working on in the state for primary care. I think we're going to see a number of great applicants come to this effort and lead to really innovative and thoughtfulness to making sure we can make a primary care system work well for our state. So again, just really a great deal of gratitude to this group.
Dr. Hemmings may have a comment, and then I'd like to make a call if there are specific proposed edits to the draft charter or concerns, because just to be clear, like our role today is to vote on the draft charter. Dr. Hemmings, do you want to share?
Yeah, just to clarify, you just used the word draft, so we're not voting to approve this actual charter. We're voting to approve the draft with the understanding that it will be finalized at some other point, which will come back to the board.
No, I think we are. I'm in draft because that's what before us now, but I think we are voting to erase the draft part
So
and approve the charter.
So I am concerned, like Phil is, about that there's only one consumer on this committee of 18 members. And I was trying to see if there was a definition of some of these roles? Because I don't understand. For example, where it says primary care workforce expert, who would that be? Like, what credentials would someone need to have to fit into that role? Especially care provider, I get. Primary care team member, what would that be? Just like someone who's doing data? I don't know. So, and is it necessary? What would be their function on this committee that would be so relevant rather than having a consumer? And then even consumer says health equity advocate. So it almost puts it into the space of someone who has who's not just strictly a consumer of primary care services. Yeah, I'm just concerned about it's a lot of people, 18. What I see here is that what happens is we move forward, we vote on these things, and then there is no room to make changes later. And then we're kind of stuck with it. So even thinking about primary prevention, and thinking upstream, I would like to see changes made now versus let's kind of go along with what it is and just see how things shake out. And it would have been helpful to have a description of what these roles are, what would they provide to the committee that would enhance and further the mission of the work that this committee was put together to do. My 2 cents. So I would not be voting for this draft as is.
I'll respond if you'd like. Sure, just a quick reflection and the question about, are we consumer focused, and does the charter speak to that orientation? And also this notion that arguably, and we could debate whether or not what I'm about to say, makes sense in the long run, but arguably each one of these humans are consumers of healthcare, have family members who have struggled in primary care access, have orientations around their own lived experience. And so without trying to prescribe very specifically tightly defined seats and an expectation about which voice they're bringing forward at what point, really relying on the facilitation of the committee work overall to make sure that that orientation is constantly driven. So it's hard to figure out a committee composition that would kind of strike all the right balances of interest. And so this was our best guess at the time, around here's a framework of the types of roles that we would want to make sure we had some deliberate inclusion in. And of course, there are others that aren't represented here that could also, are important to acknowledge. Your comment about the size of the group, that definitely, hit our attention as well, in terms of how to manage a group of that size, the agenda building to keep focused on the objectives of the committee. Those are all really important points. It's not an easy task, no doubt.
Yeah, we also wanted to keep it broad and not put exact credentials in there for each member, so that if the right voice for the right person was there and they fit the seat, that they could fill that seat. And to echo Brenda, that each member is a primary care consumer and their voice is heard. So that was kind of the argument that was in the conversation. So
I'm gonna make one comment and turn it over to Bill. Just that, I think we have made seen challenges in other committees that are super, super prescriptive, and then it's very hard to fill around well-rounded committees. So I think you're wise to learn from previous experiences. And then I had a very positive reaction to primary care team member, but I guess I want to test my assumption about what I saw in that role. I read that and I thought of the medical assistants, the CNAs, the social workers, the cadre of people that work around a primary care provider to actually make that cohesive care for the patient. That's the intention. Okay. Yeah, exactly that. Tony, go ahead. Bill. Bill. Sorry.
Suggestion. As you asked earlier, there might be some suggested edits to the charter. So I would suggest, this is a kind of partial suggestion, is that on the section 4 composition, that the maximum number of seats for consumers / patients that be increased to 3, that healthcare payers be increased to 3, that healthcare purchasers / employers be increased to 2, and that if the part that's the part I specifically recommend. The general suggestion is to either expand the committee, which doesn't seem like a great idea, but I would leave it to the co-chairs here, Brenda and Melina, to identify areas that could be other categories that could be reduced to keep it within to 18. One general suggestion would be, if it's those people who are here identified as experts, they could be the ones who you tap from outside, like bring in a consultant on, there's a primary care workforce expert. You bring that expertise in through a report, through a participation in a meeting, without having them be a member of a committee. There's also one here on the legislature. There's actually 2. Expertise in policymaking. Again, you can get that from outside the committee, bring it in to the recommenders, the decision makers. So that's, I'm not going to. I suggested that it is not overly prescriptive specifically on how to reduce the others to bring it to 18. But that's a direction you might want to pursue, is look at the areas of where we could tap into that expertise without having to be members of the
I agree with that.
Okay. Go ahead.
I appreciate those reflections. I would promote us to come to some decisions today in the interest of this body of work. It is necessary. It is now. We've already discussed that last meeting at the retreat, that we really want to get this going. And I would just caution us not to delay it further. So I think that maybe we could just reflect upon that. I would just also observe that there's 3 primary care providers on this list, the people doing the work. And so I just worry about, and I appreciate the interest of, full representation, but not to exclude from everybody here, but I'll just selfishly say, working in the trenches, there is a reason fundamentally why people are not going into primary care and they're leaving primary care. And I think we should really emphasize that voice, because it hasn't been the voice that's heard. And I think part of our intention, if we're going to create a composure of this group, is to make sure that we do have that as an emphasis. And I would suspect that, the input from primary care that came to this, that supported Melina and Brenda in developing it, that was a strong focus of that. So I know that we want to be very, and the enemy of good, is perfect with this list to having this. But I just think I worry about us getting too large in this. And I would make the motion fall your lead, Bill, that I do agree that if you were to remove the experts, that input could come through other forms, as well as the legislative aid. And perhaps that's a space that we might strike.
An alternative consideration would be to move forward with a cap idea that you just described, and recognize that the deck here could exceed a total number of 18 people. In other words, if you said you wanted not to exceed a cap of this many consumer patients, a cap of this many health insured plans, it doesn't mean you have to carve out or overly prescribe the rest of the composition of the committee. And that the deliberation about who applies, how those recommendations come forward to the board, is the process maybe to spend some time and attention on. how do those recommendations? What are we vetting for? How do you ensure you have geographic representation? You've got, because this is one of many slices of the composition that this board is going to be ultimately approving too. So that's another option, would be stay open, see what happens in the recruitment and the selection process, signal to those for whom we'll be recommending a composition to this board. This is the whole menu set of what we're interested in evoking through the committee process itself. And then you're basically buying yourself time for a future decision.
So are you specifically saying leave it as is and wait until we?
No, I'm specifically taking the recommendation of a not to exceed cap and suggesting you can lay it in there without actually deleting anything else off the list. So you can still leave policy as an example, as someone who understands how the legislative concept works through the committee, that voice is really still important to integrate in the body of the committee's paper and not necessarily get so fixed on the total representation mix of the entire composition of the committee that'll come when you start to see the talent that applies to the committee itself.
Because it's a group of 18 and
Yes.
these are maximum amounts, not required.
Yeah. So you don't have one singular part of the puzzle dominating the conversation. That is also an important consideration in the max not to exceed.
Yeah, so what you're suggesting is leave it as is, but add in.
Add your max.
Which then, if you add up the column, it would add up to more than 18.
More than 18.
It'll come back, say like, it could be 9, no more.
Could be 9. We'll see what happens. Yeah.
I would like to make sure that, there is, I think that's fine.
So the edits, just to be clear for a future motion, would be the line that says consumer health equity advocates would be increased to 3. And the line that says healthcare payers would also be increased to 3. Is that what I heard?
And healthcare purchasers and employers up to 2.
And thank you so much. Purchasers and employers to 2.
And also the line on number 2 should be consumers/patients.
Consumer patients, sure.
I'm glad that we're reaching a consensus or a joint thing here. I actually like spelling out health equity advocates.
I'm fine with that too. Including
Okay.
that. There's just insert patients.
Okay.
Yes.
I have one last comment, and it's regarding comment that was made about that each person each individual on this committee is a consumer. However, I think, just even for us here, there's a different level of access, right, than just a lay consumer that we have, and all of these people here will have, that a true consumer that I'm thinking about doesn't have, right? So there's certain privilege, I think, that when we enter the healthcare system that other people do not, and I would like to see those people represented. Like the patient that I deal with who has no idea how to find a PCP, primary care provider, right? Who is struggling to get an appointment, right?
Yeah.
They don't have the knowledge and the privilege that we have because we are familiar and we're part of the system, even though we may not be working in primary care. And each of these individuals, yes, certainly they access healthcare and they may, access primary care services, but they're not accessing in the same way. So that's what I'm thinking of. And that's always been my issues with all of these committees, that it's very heavy with people who work for institutions and have certain expertise, certain privileges.
Mm-hmm.
And I think that's great. However, the voice of the lay person is not usually represented. Yes, we sit here and we sometimes can speak, but why not just have them speak for themselves?
I think in recognition of that, sorry, Melina.
No, that's okay. And yes, thank you, Dr. Hemmings, for bringing that up. And that's very important. And I think that is where we found it was very important to have the health equity advocate be a member.
I wonder
And-
if we need,
But yeah, thank you. No, go ahead, Brenda.
because these are maximum seats and it's possible that people are considered to wear two hats, I wonder if with the consumer patient health equity advocate line, there should be a little asterisk on there where like those people serving those seats are only those roles. They are not also a tribal health provider or a health center administration, right? So, okay. Is that?
And also that there's intentionality around actually marketing and filling those seats. Because what I hear a lot from these committees is, oh, we tried, but we couldn't get anyone, right?
Yeah, I think
not that there's a spot there, but that there's intentionality around the recruitment of filling those seats that are supposed to be quote unquote consumer.
I think we're all saying exactly the same thing, and I'm so excited about it because I'm now thinking about our ombudsman friends that are in the room about the public testimony that we've received relative to access to primary care in the past. I don't think it's going to be hard to recruit those spots at all, and I think the intention of what we're talking about is exactly the same.
I'm going to make a motion. And I think, so let me repeat this, see if it reflects everything. So I move to approve the charter as drafted with following amendments. In the composition, section 4, consumer, we'd add the word patient. So it'd say consumer patient health equity advocates with a maximum number of seats is 3. Healthcare payers, the maximum seats of 3. Healthcare purchasers, employers with the maximum seats of 2. We would put some sort of notation next to the consumer patient health equity advocate line to say that those seats should not be dually filled with any of the other categories. Motion on the table.
Do you need an actual motion and then a second, or?
I'm moving that.
Second.
Okay.
This is Bill.
Okay, thank you. Suzanne or Summer, I don't know who's doing our roll call, but take it away, please.
Are you there, Suzanne?
I'm here. I'm happy to do the roll call.
Okay.
Give me just 1 second.
Do you want to correct?
Okay.
Who did?
That is ruled.
Sorry about that. Tony German.
Aye.
Dr. Hemmings.
No.
Kirsten Isaacson.
Yes.
Brenda Johnson.
Yes.
Bill Kramer. Sorry, I didn't hear Bill's reaction.
Yes.
Melina Moran.
Yes.
Peter Starkey.
Yes.
Hayden Rookley.
Yes.
Thank you. You have 7 of 8 members approved.
Great.
Motion passes.
Thank you for the deliberation, edits, the work. The work continues. Look forward to it. Okay, with that, we'll move to Sarah Present, Chair for the Public Health Advisory Board, with us to review the board's updated charter and bylaws. As one of OHPB's committees that's established under statute, the FAB is directed to bring changes to its charter and bylaws for our approval. So after we hear from Sarah, we'll be asked to vote on the approval of FAB's updated charter and bylaws. And thank you so much for joining us.
Hi, everybody. Thank you. It's really nice to be here. I'm really glad that I had the opportunity to hear most of your meeting. You have a lot of things on your plate, and I'm really impressed, and thank you for the work. Again. I am the current chair of the Public Health Advisory, which is one of the subcommittees of the Oregon Health Policy Board. I am a family physician and health officer for Clackamas County, Oregon. I've been a practicing family physician and health officer at the same time in Oregon for about 14 years now. And so it's not unique, but it's a fairly unusual perspective to have that crossover between primary care and public health work in the governmental public health system, which puts me at a really interesting. I really enjoy being able to be the chair of FAB this year as we're looking at really reevaluating our modernization work, evaluating a lot of what we do in the setting of massive funding cuts and how we prioritize things. So a lot of what FAB is working on, I'll go through here. But there are certainly a lot of questions forward. And I think it's part of why it's so interesting to hear about all the other work that you guys are doing and talking about breaking down silos between subcommittees. I think there's a lot of opportunity I'd like to explore with you guys and how the Public Health Advisory Board can work with some of the other subcommittees on advancing public health services and healthcare services to all Oregonians. So, first slide, our purpose today, we're going to share our updates in our 2025 charter and bylaws and hope to get approval of them. Talk about some of our focus, show how we align with Health Policy Board and some of your priorities, and look for some of those opportunities for collaboration forward.
Sarah, I'm so sorry.
Do I have to talk louder?
I
guess
not.
faster.
You're fine, just faster.
Okay.
We are running pretty late. Not your fault, but
So the last time the Oregon Health Policy Board reviewed the FAB charter was in 2020. So a lot has changed since then. We've had a lot of kind of updates in how we use public health modernization across the state in our local public health departments. We have new structures for our accountability metrics and evaluation. We have an increased focus on health equity, and we have a lot of lessons from the pandemic that has reshaped our priorities. And like I said, like every other part of the healthcare system right now, we're facing significant financial cuts with flat funding at the federal, state, and local levels, which really leads to our board needing to lean in to provide direction for public health priorities in Oregon right now. Next slide. I'm not sure who's running the slides, but okay. So the Public Health Advisory Board is an actual board of governor-appointed governor-appointed members. Unlike some of your other committees, we are an actual board ourselves. 21 members, with 18 of them being appointed by the governor and 3 officio support from OHA. The intention for FAB is to be one table that brings together partners across the public health system to provide direction and recommendation. We have representation from local public health authorities of all different sizes. We have tribal representatives, public health and healthcare system experts. And in the 2023 legislative session, we increased our numbers to include a health equity specialist, representatives from community-based organizations that get modernization funding, one rural and one urban, and then somebody who represents preschool through high school education as well. We do most of our work through subcommittees and work groups. The subcommittees are defined in our bylaws and meet on a regular basis, and the work groups meet as needed. Next slide, please. I'm a little bit off. So our updated charter and bylaws, you have, I think we skipped a slide. That's okay. Basically our statutory obligations are, my slides are a little bit off. I'll go with this one. Our updated charter and bylaws, hopefully you have seen, they were with your materials for this meeting. In the last couple of years, we really worked on strengthening our commitment to equity and the community voice within these, and clarified our roles of oversight as a board in the modernization process. So public health modernization was really a statutory attempt to define foundational public health services and programs about 10 years ago. So that is where FAB was established, and that is where much of our statutory obligation is still relies. How we approach that statutory obligation as a board overseeing public foundational services that local public health departments provide has changed appropriately depending on time. So we have been focusing on defining and increasing our role in facilitating alignment, and our focus on accountability metrics and equity benchmarking I'll talk about a little bit more. If you look at our charter, you may see we have it set up that the statutory obligation is on the left and how we approach it is on the right. And you may notice that over half of them, 7 out of 13, reflect a responsibility to work with Oregon Health Policy Board, which is part of why I'm here today, to make sure that we can focus on those areas of alignment. Next slide, please. Our focus areas currently, I have alluded to already. Public health modernization, really working on how we look at our overall capacity and how modernization is being implemented across the state of Oregon, focusing racial equity in all of our recommendations, working on how to provide guidance on funding and resources when we do not have sustainable funding, but how can we potentially find sustainable models without sustainable funding? And then communicating and advocacy, so articulating the value and need of public health. One of my goals as our chair this year and next year is really connecting with people like Oregon Health Policy Board and other subcommittees to think about how public health system and the governmental public health system can work towards helping CCO metrics advance, to work towards helping HITOC metrics advance, how we can work together to articulate the value of what resources we do have in public health and use them most efficiently. Next slide, please. This is an overview of our current public health accountability. So this, again, was put in statute that we need to come up with metrics. We have a subcommittee that's been working on them. They have changed significantly in the last several years, a lot having to do with lessons that we've learned from public health service delivery through the COVID-19 pandemic. The way that the modernization bill has structured the funding is that funding was focused on certain programs first, and as we move along, we expand the funding and the work to include other programs. So our first focus was on communicable disease prevention and environmental public health. Prevention and health promotion and access to clinical preventive services are the other two foundational program areas that do not yet have accountability metrics, but we're looking to identify those in the next few years. And I think that's an opportunity I'd like to keep on your mind of how we can align them with other metrics working towards the same goals. So sexually transmitted infections, we have changed some of these metrics. I know we have limited time. I'm sorry to go through this really quickly, but we have really looked to focus our metrics on things that are doable for local public health agencies in partnership with our community partners and our health systems. So public health goals that the metrics will actually show what an LPHA is doing. So we used to have gonorrhea rates. Gonorrhea is not something that a local public health authority really has a lot of control over prevention of spread. Syphilis is something where there's a lot more case management and a lot more engagement with each case and a lot more engagement with community partners and health systems. And it really does take an overall approach, but there's some sort of control that showing an improvement can actually show that public health is doing improved work. Right. Vaccine preventable diseases, that is certainly something we've tried to align with CCO metrics forever, and we all know that that's a big public health priority. And then the environmental health work, regulatory environmental health, like food, hotel, pool inspections are supported financially through fees. So modernization of environmental public health is really looking at what actually in the environment affects our public's health. And so we've been focusing on extreme heat, wildfire smoke, and other sort of climate changing effects on our population. So these are things that are really within the control of public health departments and our epidemiologists and the data systems that we have. So that's what we currently have. Again, we've had a lot of conversation today around the complications around incentive funding for programs looking at value and performance. And I think we have a lot of the same questions in public health. Next slide, please. I've already alluded to many of the opportunities that I see for collaboration with Oregon Health Policy Board, as well as other subcommittees. We really do want to ensure that the public health delivery system is aligned with the healthcare system delivery system, and that we're all using each other's strengths appropriately and efficiently. We certainly need alignment under under-resourced and stretched systems. Yeah, I think there are a lot of opportunities I'd love to talk more about. Time allowed. I think that's wrap it up. If you go to the next slide. So our requests today are for the approval of our updated charter and bylaws. I'm happy to answer any questions about them. I would like to think or just bring to the table that I'm here. I'd love to be able to come to all of your full meetings every time. Probably I can't, but how can we bring the Public Health Advisory Board and our work in more alignment with other subcommittees? And I'd love to hear your thoughts and comments, questions.
Given the recent crisis with vaccine guidelines, my question is, what's your role vis-a-vis the West Coast Health Alliance and the work that's being done to develop its own guidelines since the collapse of the credibility of the Centers for Disease Control?
So the West Coast Health Alliance is made up of public health leaders from, the Western states. Naomi is the OHA Public Health Division Administrator, and Dr. Dean Seidlinger is the State Public Health Officer. They are both ex officio members on this board, and they are both connected with the Governor's Office and the work on the Western States Alliance. So our board does talk a lot about important activities in the public health crisis around attack on science and informs. We're able to have conversations with our OHA leadership who then can bring that onto that.
So that liaison, if you will, or connection to the West Coast Health Alliance is part of the work that you all do.
I think we're all very, very interested in it. It is not, we do not have a direct link to the West Coast Alliance other than through Dr. Seidlinger and Administrator Briggs.
There's a role in communications, I understand. So is there a role that you play in communications regarding vaccine guidelines?
Yes. I would say indirectly, absolutely. I think that we have a lot of the public health structure in Oregon is such that the county has local public health authority, right? FAB is someplace where LPHA representatives and our community partner representatives all come together. We have an opportunity there to communicate on alignment and dissemination of that information through the public health system. I think if FAB is directly supporting West Coast States Alliance, which I believe we did talk about that around the COVID vaccine guidelines, then all of our local public health agencies can also say, yes, we FAB is one of our overarching communication things. They are aligning with this. I don't know if that's answering your question, but it's really, we don't have a direct communication to public health role. It's more of a convening table where each individual has a lot of representation on their communications. And we advise OHA Public Health Division, and that is really where the advocacy is.
A more related question, if that's okay. It's just on the measures.
Yeah.
I see that there are two there related. One, childhood immunizations, one for adult influenza.
Yeah.
Given the rising concern about people who are don't want to get vaccinated because of misinformation and disinformation at the national level, is there a consideration of expanding that list to include ones that might not have been considered important before, but now are important? part of a general question about to what extent is the vaccine issue up priority?
Absolutely. So the public health accountability metrics around vaccinations, our local public health authorities have always had immunization programs. Many of them provide direct clinical services, including vaccination services, primarily for uninsured adults or through the VFC program. Many LPHAs kind of help as technical assistance for VFC providers in the community. And we are responsible for the school exclusion process through statutory requirements. So historically, our focus has been on those sort of school exclusion vaccines because that's where our governmental responsibility is. We certainly expanded it to adult influenza and respiratory around COVID. When we had increased capabilities during the COVID response to really work with our long-term care facilities, which is another huge vulnerable population, and had many resources that look differently across the state to help ensure vaccines were brought to long-term care facilities. Again, that's one of the challenges of funding. We're not doing that as well anymore because many of us don't have the capabilities to have that relationship. We still have immunization programs at each department that are focused on our statutory requirement of school exclusion. I think if we wanted to look at increasing many vaccines and vaccine communication as one of our metrics, that is someplace that we could certainly align more with the healthcare system and with other subcommittees of Oregon Health Policy Board, as people's primary care providers or their healthcare system is actually more of a trusted source of information at times. So, and working with our community-based organizations, that's where those partnerships are a big part of how we see success in governmental public health, and figuring out who the right partner is. And that is, again, back to part of why I think coordinating our metrics with primary care and CCO providers is vitally important to making that work move forward.
Thank you for presenting this, Sarah. I'm curious, and your patience with our wild meeting today. I see in the charter, part of the charter is to make recommendations to the health policy board around a variety of areas. Do you think that that will be something coming to the board in the coming year?
I think that we would like to explore how to do that better. Again, a lot of the recommendations to the Oregon Health Policy Board is in statute. The statute was made during, 10 years ago when healthcare transformation was also happening. The CCOs were being formed. And honestly, there was some thought that public health would move away from, clinical services. We thought it might look differently at this point. I would like to be able to have more interaction, both making public health recommendations to you if desired and asked, and also getting more feedback from you guys on public health. That does take, our time and staff time, and I would be curious if you had ideas of how to meet that statutory requirement any better.
Yeah, it'd be a new or an area that the board hasn't been very engaged in historically, but especially when we think about moving back into CCO procurement, it seems like having some insight from the corporate advisory board would be.
Yeah, Brenda came to to FAB, and we did submit a letter of recommendation. We'd love to have more conversation.
It was very valuable letter, as I recall. So
I think you're both. elevating an issue I think the board hasn't yet reconciled, and as a former not very effective liaison, my apologies to them. I recognize that finding those places of intersectionality are really critical to define and then create the mechanism of connection that may look not traditional to the liaison role that we have with other committees. I think your point of the FAB is a board in and of itself, it has its own body of work. So I know as just personally, I struggled finding my spot, which had nothing to do with any there. But like, where are those places of intentional design where overlap is and where the two bodies work independently and just are aware of one another's work. So I think there's future clarification to be done there to make that connection more durable.
So look forward to doing that.
Thank you. So with that, there is a request to approve charter and bylaws.
Question. Why are we then having to approve their charter and bylaws if they're their own board? And I'm confused about why we're having to have any say at all about their charter.
Because the legislature said so.
So they're their own board, but they also have some reported structure to health policy board. Okay, that's all. I was just curious.
It is confusing for
sure. Yeah.
And I think, one of the big reasons I want to be here is because when you read this, it is really, when you read the statute, there's a lot of connection that's assumed that, I think we all can. So I think we'd like to explore where it does fit to be aligned, where it doesn't, but be more aware.
I think also considering the federal changes that are happening, especially to vaccines, I think it would be helpful to have a little bit more of a closer relationship with FAB. I used to be on the FAB committee. Yeah. Oh, long time ago. So that's my 2 cents.
I'm looking for a motion.
This is Brenda, so moved.
Mr. German, second.
Motion and second. Suzanne, will you lead us through roll call, please?
Tony,
Yes.
Dr. Hemmings, Kirsten, Brenda, Bill,
Yes.
Melina. Oh, Melina has left, I believe. Hayden.
Yes.
And Peter.
Yes.
Motion passes.
Thank you for joining us.
Thank you. I promise I won't give you too much more work.
Okay, I'd like to welcome Ian Strauss, leads chair of the Healthcare Workforce Committee, and lead staff, Deepti Shinde, to presenting a new membership slate for OHPB approval. Thank you, Ian and Deepti, for your patience. Thank you for trimming your presentation. Take it away.
Oh, excuse me. Okay. I'm Ian Strauss. I use he, him pronouns, and I have the pleasure to chair the Healthcare Workforce Committee this year. Deepti, do you want to introduce yourself to the group?
Sure. Hi, good afternoon. My name is Deepti Shinde. I'm the staff for the Healthcare Workforce Committee, and also I work in Oregon's primary care office.
Okay. Today, we'd like to bring the proposed new members for the Healthcare Workforce Committee. Deepti, do you want to give the kind of background on all of this? Do you want to do these slides?
Yes, sorry, I am having a little bit of internet issues, so I might turn my video off. I apologize. I'm going to be starting off our presentation by giving you a little bit of information about the committee. The Healthcare Workforce Committee was established in 2010, and it's one of the original committees under the Health Policy Board. Unlike some other committees that you all oversee, our committee doesn't have specific seats that are assigned to certain members. We are just required to include individuals who have the collective expertise, knowledge, and experience in a broad range of health professions, healthcare education, and healthcare workforce development initiatives. The committee right now has 21 members, with 3 members who are terming out and ending their second term, and then 2 members who are choosing not to continue with the committee in 2026. So we have 16 committee members who will continue with us for 2026. Next slide, please. So the next 2 slides are the list of members who are remaining on the committee for 2026. I will not read their names, or you have the information here. We're a little short on time, so we'll keep moving along. Next slide, please. Great. So the next few slides are going to take us through the process that we used for recruitment. We followed, next slide, please. We followed the Oregon Health Policy Board's committee recruitment guidelines. We developed our recruitment notice in English and Spanish and posted it for about a month-long period in September and October of this year. We had a review committee that included OHA staff, our chair, Ian, and members of the committee. We invited applicants to do a virtual interview gathering, and we also asked them to complete a survey with information about being a committee member so that they understood the requirement and also what was being asked of them as a committee member. We went ahead and conducted interviews. We completed the Policy Board gap analysis tool, and then we selected applicants to serve on the proposed committee slate that we're presenting here to you today. Next slide, please. Great. And so during the application period, we got 27 applications. We invited everybody that applied to participate in the virtual interview gathering. So we didn't screen anyone out at this point. Out of those 27, 20 applicants were able to participate and did the group interview with us. There were some whose commitment changed during that time period, and so they dropped out. Others were not able to do any of the times that we had had during the week. And then we also had a couple of no-shows on the interviews, and so they didn't do an interview. So out of the 20 applicants, we selected 9 that we're inviting to membership for the committee, including 1 student who will serve as a non-voting member. We want to acknowledge that this is a larger number than in past years, and that's mainly because for 2026, it's going to be a really busy year for the committee. The committee has 2 major deliverables that are due to the legislature in early 2027. And those are products that you're very familiar with, but they're the Healthcare Workforce Needs Assessment and then the evaluation of the Healthcare Incentive Program. Both of these deliverables really require significant engagement with the committee. And so we wanted to make sure that we had a large enough committee that both had the subject matter expertise and the capacity to do this work. And so in making our selection of these applicants to move forward, we considered their responses in their application and in their interview gatherings, their lived and professional experience balanced with the existing representation on the committee, and also that impact on the demographics and the areas already represented. Next slide, please. Great, and this is just a little bit more information about the gathering. They were given options to select their time and day. They received information about the committee goals, the time commitment, and the financial compensation. They were also provided the interview questions in advance, the day before the interview. And then we also provided them a little bit of information about who they would be chatting with during the interview. And then during the interview, we asked questions about why they were interested in joining the committee and other questions. And then they were also given time to ask us questions about the committee's work and also any other questions that they had. Next slide, please. Great. I will turn it over to Ian to talk about the proposed new member slate. Thank you.
Okay. So we looked at our group of applicants through a number of different lenses. We looked at lived experience, geography, gender, race, and age, among other pieces. And those were our key data points. And that was really to make sure that we, as a healthcare workforce committee, showed input and really could draw on input from all over the state in various different life situations. Next slide. Now, we wanted to fill out, healthcare workforce is a fairly complicated question. When we look at it, we have to look at people's lived experience in where they work, in where they live, in where they come from. I'm saying kind of the same thing over again in a different way. You can see here, we are looking at people with coordinated care experience, nursing workforce members, traditional healthcare workers, as we're making sure we fill out the primary care directive from the Oregon Health Policy Board, that we really have people who can represent all the different areas of primary care in the conversations about workforce. We're looking at our strategic priorities, including advancing wellness and retention in the workforce, making sure we're providing feedback on behavioral health, pediatrics and other primary care, oral health. So really having the right people in place to have the conversations we need to have. Next slide. The next 3 slides are a list of the folks who we did decide to invite to join the committee. I'm not going to go through each one, as I don't think we really have the time for that. So why don't we go forward 1, 2, and 1 more, 3. Now, this group, should you approve this panel, will start with the committee in January of 2026. We still do recognize that there are gaps in our existing team, but this was the group that we could bring in to, we believe, hold the best conversation for the Healthcare Workforce Committee here in Oregon. Next slide. Just a quick look. As I said, we looked at geography. As you can see, the existing committee covers most areas of the state. Next slide. Is gender diverse. Next slide. At least has representation from the larger racial groups here in the state. Next slide. And a good age range. We also have people who really, as I mentioned before, fit all of the lived experience areas that we see make up primary care to be able to address the conversation that the Oregon Health Policy Board that y'all have let us know moving forward. Any questions or anything else I can fill in on?
About Dr. Hemmings, full disclosure, I'm on this committee. And I think I have made this comment at the committee that I wanted to say here publicly that I would like to see in the future that we make a conscious effort to advertise and solicit students from other universities besides OHSU. The current student who's on the committee is from OHSU. The recommended student who will be joining the board next year is also from OHSU. And I think it would be a great opportunity to open that up to other students who are within the state of Oregon. That's my comment.
Thank you, Dr. Hemmings.
Any other questions? Motions?
I'll just say one, and it's really a representation of this slide that talked about gender diversity, and it is still a binary framework for male and female, and just this is probably just for all of us around how important it is to have a scale that is non-binary as we think about the demographics for gender diversity. So just thought I'd say that now and have no concern with the slide as it's proposed. Call out.
I think Brenda should make the last motion.
I'll move approval for the recommended slate from the Healthcare Workforce Committee.
Second, this is Peter.
Great.
Ready to call for the vote?
Please, Suzanne.
Okay, Tony,
Yes.
Dr. Hemmings, Kirsten,
Yes.
Brenda. Sorry, I didn't hear Brenda's response.
Yeah. Yes.
Thank you. Bill?
Yes.
Melina has left. Peter?
Yes.
And Hayden?
Yes.
Thank you. Motion passes.
Thank you. Thank you, Ian. Thank you, Deep, for shortening your presentation and taking us through that.
Absolutely. Thank you for your time.
Yes, thank you all.
All right, and with that, we are to our last agenda item, which is to appreciate our fellow board member, Brenda Johnson. We have full time for the no, but we do want to acknowledge your support and leadership on the Health Policy Board. It's been a wonderful 8 years. None of us have been here for those full 8 years, so we're losing a very senior member of our board. But you leave a lot here, and I think that's both. You spent many years as the liaison to the Workforce Committee, and brought others behind you. I feel like you've done a great job about pulling people and stepping out and pulling people into roles, which is a sign of a true leader and a gracious heart. But I want to acknowledge that Brenda also left us with some very specific tools. Like, we acknowledged the reading of the health equity definition this morning, but also we have a written governance document because of Brenda's leadership. And so you leave us not only benefiting from your input over these years, your service, but with some lasting tools that make us more effective and better. Thank you very much. I'd like to welcome any other board members or OHT staff to share their appreciation as well.
I'll jump in quick. I am just really grateful to be able to work alongside you, Brenda. I've learned a great deal at this board coming in the last couple of years, and I really have just appreciated the elegance of your collaboration on this board and facilitation. It's some really hard work. Some really tough, specific things are shared that are going to carry forward, and really keep us focused, particularly on health equity. That is just really something when I joined the board, coming to understand how we could make sure that is a priority. And I just really appreciate that. And just your facilitation and the conversation and your board leadership too, as mentioned with the governance, and then just learning how you've facilitated conversation here, and certainly some tough topics. And so I just I've gained a lot. And you felt gratitude too.
I'll add on. This is Bill Kramer. Have two levels. One is just a personal level. I feel like I've learned a tremendous amount by getting to know you and seeing how you operate here on the board. Sometimes we have a little bit different perspectives on things, but it's never presented as, it's never come across as an opposition. It's like, oh, well, here's another thing to think about. I really appreciated that, the way we had dialogue and interaction on a variety of issues. I think that our core values, though, are very much shared, and that kept us together in that dialogue. From a broader perspective, I really admire the work that you've done for the board, as a board process, board structure. You really care about making this board effective and having an important voice in health policy, and keeping us all grounded in the vision and the values of improving care for all Oregonians. That's come through just almost everything you say. So you leave a real imprint here on the board and on the state of Oregon, and all Oregonians for the work you've done. And I appreciate it, and I think we all just appreciate all that you've done for all of us.
I'll go.
You go.
I think when I joined this board, you were the first person to reach out, and I appreciate you taking the time to kind of orient me to the board and provide some insights. And I wish you well. I am most concerned about you. I know this is your partner here. But I wish you well, and I'm sure you'll still be around and involved in different ways, and will continue to have a tremendous impact on the state of Oregon as it relates to health. So nice to have met you.
This is Peter. Ditto on everyone else. I think in addition to what everyone else has said, I think also just your character and the culture of you that you bring to this board, I think is going to be sorrowfully missed, especially by me. Anything unhinged that comes out of my mouth once Brenda leaves, it's Brenda's fault for leaving. We're at statute for limiting her. But I know personally for me, I know that I've joked about it, but when you speak with such intention and always seeking to build bridges, seek understanding, with a serenity that is just admirable. It has been, I know that you talk about North Star, but that's why frequently I'll just be like, Brenda needs to talk first because I need to ground myself. And I'm going to miss that immensely, and just miss you. And I come down to Medford, so be ready.
Say a few things. Yeah. Just it is an honor, and thank you for your very warm comments. I was thinking a little bit about this being my last meeting, and just what I'll miss and what I hope for you all. I think I first want to talk to you, Claire, and your team, and to really acknowledge the incredible amount of expertise and hard work that you and so many people do on behalf of the agency and that really support this board. It's phenomenal, and having like an inside view of what happens a little bit under the hood, it's even that much more remarkable. So, I don't think this board and our structures would be anything without the incredible support of you and the team, and so just thank you, hats off, and stay with it. It's a big body of work, and I think my first orientation to the board was so confusing. It's such a big job. And so my comments for all of you is, really to encourage you to continue to stay the course. I know you will anyway, because I have such deep respect for each of you as individuals. And then I think about the power of the collective, right? Think about our new team members who get to join at this wild moment in time and to shape the conversations through thoughtful intention. I've been struck by how the board's work and the agency can shift in small degrees that actually have really big impact downstream. And so to encourage you all to never underestimate the power of your own perspective and the way in which you lean toward one another in shaping what our future could look like together. It's been an honor personally and a privilege to serve. I'll miss you all. I'll be watching. I'll be watching and just feel really grateful for the opportunity to be in service in a specific way. So thank you for this, and I feel complete. Yeah, thank you.
Now's the part where I would be handing you a beautiful plaque acknowledging your service. It is behind locked doors, unfortunately, due to an illness. But it will be coming to your home. Thank you. And thank you. Thank you.
Yeah, it's my privilege. Thank you so much. Yeah.
But that is the end of our 2025. The most everyone next year. Thank you, Brenda. And for those who are available, having a non-board,